That's it, that's good, yeah. That's the cash point.
Hi ladies and gentlemen, I'm sorry we're a bit slow starting the meeting today, but there's a few papers to hand out. I'm afraid I haven't got a chair or a vice chair tonight, so you're going to have to elect a chair from the panel. Do I have any nominations? It has to be a panel member, not a sub. Obviously we've got several subs.
I nominate Bill.
Yeah, I'll second that.
Yeah, is everybody happy with Bill to take the chair?
Yeah.
Thank you.
All of those happy. You've got any 2 million people. I'll tell it.
Right, good evening everybody. Thank you for coming on to today's meeting. Bear with me 1 second. If we go on to straight onto the agenda. If I did miss anybody, apologies, there's a sponsor form coming round. If I miss you, I'll pass it round to full council again next week. Just quickly, I'm arranged to do a wind walk in October to raise money for the mayoral appeal. It will come round. Anyway, item number 1 is the evacuation procedure. We're not expecting the fire alarms to go off, so if we do, we'll treat it for real. And if we can evacuate the building, following the fire exit sign, so it's out of here and back down the main stairs, out the front door and meet across at the Yorkshire Bank. It's also a good time to remind people to turn their phones off or put them onto silent. Thank you. And just to advise people that most, if not all, of our meetings are recorded now. So they're recorded and put out on YouTube the next day or the day after that. Item number 2, to receive apologies.
I have apologies from Councillor Paul Shepherd, Councillor Keith Congarter, with substitute with Ian Bonner, Margaret Pomfret, substitute Mr Watkins, and Catherine Brindley, substitute Councillor Wilson.
Okay, thank you.
Yes.
Item 3 is to confirm the minutes of the meeting on the 6th of July. I wasn't there, so will the people confirm their true record?
Yes.
Okay, is that agreed? Yep. And item 4, the declarations of peculiar other interests in accordance with the members' code of conduct, not the party whip. Yeah, Councillor.
Thank you, Chair. As I'm not normally a member, it won't be printed. I think the only one relevant to the papers is my directorship of NABSELF, which I've received dispensation from the Standards Committee to vote and speak.
Okay, thank you. Okay, item number 5 is public consultation. Have we got a lady here to speak?
Yes, we've got Denise Wainwright. She'd like to speak on item 9, Chair, but she has to get away, so she wondered if we could take that now. Not the item, but hear what she has to say now.
Okay, then. Yeah, Denise. Sorry, I'm looking for your name.
Okay.
If you'd like to come forward, just make your point. So it's just a timer. You only get 3 minutes.
That's why I've written it down so I don't forget. Tricia's asked me to speak about, it's the sensory impact assessment, which is a traded out service of children's occupational therapy as part of South Warwickshire Foundation Trust. I have a son who's 6.5 and he has sensory processing disorder, sometimes called sensory processing dysfunction. And I was told about this service by IDS, and you think, great, a service you can get referred to and get help from. Until you hear that it's traded out, it's not part of core services anymore, and comes with a price tag of £425. And for that price, you get 2 visits by an OT, and you fill in a questionnaire with them, and then you get a report at the end of it. And that's all you get, unless you can afford the therapy, which is £75 per hour for therapy. Other than that, you are completely left on your own to do any therapy you can with your child. And unfortunately, there's a lot of misconception about sensory disorder, that they think it's just kids who don't like noise, they don't like certain foods, they're fussy eaters. But it's much more than that. My son, it controls every aspect of his life, which controls every aspect of our lives. His eating, his sleeping, people can be around, you know, you can't take him certain places because he will physically be sick because of the smell. And when you can't afford £75 an hour for the therapy, I can't help him. And this is a really ironic thing as well. I could have gone and got a private OT to do the same assessment in 2 weeks that I had to wait 5 months for with South Warwickshire Trust. The current wait is 12 months, maybe 9 months if you're lucky. But the difference is with a private OT, the NHS, education won't accept private reports because you've paid for it. Yet they're charging us for the same service just because it's got the NHS logo on it. I've asked South Warwickshire Foundation Trust for numbers of referrals prior to the traded out of the service and after, and I was told that these numbers were not readily available, so I could not have them. So I failed to see how they could trade out a service if they can't tell how many numbers were being seen by the service to begin with. And there's people that desperately, families and children that desperately need this service, but they plain and simply can't afford it. I have a friend who's got twins, and she's trying to decide which twin can have the assessment because she can't afford both. And that's the reality.
Okay, so were you about there anyway?
Yeah, yeah.
Okay. Yeah, it must be extremely worrying. Are you happy to take any questions
Yeah,
or
yeah.
points of clarification?
Yeah.
Is any member want to ask anything of Denise from what she said?
Yes, I'll.
But she's not
Good
going to.
question,
I'm only
if I
doing
can.
because you're not going to be here for the.
Yeah,
item
that's
itself, so.
You talked about being able to access private
Yeah.
assessment within 2 weeks. What was the cost of that compared
Same
to?
cost.
Same cost.
Same cost. And some of the OTs that are private are probably even more qualified than the NHS ones. And, you know, plain and simply, education, other health professionals won't accept it because they say you've paid them for it, you could have told them to write anything. Yet they're charging us for exactly the same thing.
Okay, thank you.
Okay, thank you. Anybody else? Yeah.
Just wanted to make sure everybody knows what OT is.
Yeah.
Every-
It's occupational therapy.
Yeah, sorry, you do
Yeah,
tend to fall in the
sorry.
trap of
The
acronyms,
rest
so-
of children's OT services is still included as a free service. It is purely the sensory service that has been traded out, but only in South Warwickshire. If I lived 8 miles down the road in Coventry, it's still free.
Oh, yeah, of course, yeah. Okay. Well, thank you very much for that.
You're
And,
welcome.
it's later down on our
Yes.
agenda when we're going to discuss autism, etc. So,
Mhm.
I mean, I'm happy to ask if you've got any response to it.
I mean, it's difficult to hear that in terms of the impacts of that, but I'd like to, I don't have the exact information to say how that would operate and work as a service, so what I would like to do is take that away and potentially get you an answer back in terms of whether that's what we believe as commissioners is happening and or should be happening, but I haven't heard of that before, so again it is different.
It's been happening it traded out 3 years ago.
Yeah, okay, so if I could have a look at that, if you'd be prepared perhaps to share some information with Shirley, get that written down and then I'll have a look at it for you and get some responses back.
Yeah, no problem.
To be clear from a commissioning perspective that is what we're commissioning, because sometimes we have some mismatch between that, so.
It's all on their website.
Yeah, okay, I'll look at that.
Okay.
As I think for the panel's benefit, it might be useful if we can
Yes,
also have that information.
yes, certainly, I'll do it through Shirley if that's okay.
Okay, Denise, thank you very much.
No problem.
Sorry you can't stay for the rest of the scintillating.
I'll get back to my kids. Thank you.
Is that all, is it?
Yeah.
Right, apologies, I was unaware of this, but we've got the portfolio holder that's responsible for help with us tonight. I understand, Councillor Longdon, you've got something that you would have liked us to do under any other items, but your time is restricted as well, yeah?
Yes.
So, has every member of the panel had this extra? It's got item 7 on here. Warwickshire Children's Safeguarding Board Memorandum of Understanding. Are you happy to hear it? Yeah. Okay. Councillor Longdon, if you'd like to come forward.
Thank you, Chairman. Thank you, committee, for bringing this forward. At the Health and Wellbeing Board yesterday, this item came up. It's a mystery to me why it wasn't just a report, a normal report, that was either agreed or disagreed or just noted. But there's an insistence on having it down as a memorandum of understanding, and I couldn't find out really why it had to be a memorandum of understanding. So I said, no, I want to take it back to Health Services and Scrutiny in Nuneaton, Bedworth. As I say, it was yesterday. I understand tonight that you probably won't be able to give this any sort of real consideration, and I'm happy for it to go either to the next meeting or dealt with by email, depending on what you want to do. But the chair of the board, Councillor Second, wanted it done within 2 to 3 weeks, and I said I couldn't guarantee that because of the way that meetings are set up. So it's with you. I don't see anything particularly onerous in it. It's just this insistence on having it as a memorandum of understanding, which makes me quite nervous on why it was done this particular way and why they need to have a memorandum of understanding for the processes of getting the link between safeguarding and the Health and Wellbeing Board. I was also a little bit nervous about what's happened around the country at different times, but certainly the latest one with AJ, little AJ in South Warwickshire, where the mother went to jail for 19 years for stamping on a baby and killing her. So there's nothing in there about any of this, it's just the way that things can operate. And as I say, I don't see any particular onus, it's just that the fact that it didn't come as a normal report, they're insisting on having a memorandum of understanding. So if you good people could have a look at that and give me some guidance, I'd be very happy to take that. Thank you very much.
Yeah, I mean, just to try and clarify, it's difficult for any committee or panel to get the teeth into issue that's just tabled on the 9th. And the next meeting of this panel is November. So is that too far away for this to be?
I'm happy to chair with November.
I'm just thinking there might be more detail that can come to it.
The chair of the board won't be happy, but I'm not particularly bothered about that. So you have to do with our time scale.
When's your next meeting?
At the same time, I think it's, I don't know, it's way out. About 3 months away, I think, so probably December.
I think ours is the 7th of November, something like that.
In that case, if what does the panel prefer? I mean, I think it could be put back to November if Councillor Logan isn't going to another meeting till December. Or do you just want to? There's choices. You can either deal with it tonight, or you can take it away and put any responses by email. But I'm conscious that maybe other members of the council won't be aware of it.
I don't mind, Chair. I mean, it's, as I say, I wasn't going to be, I made sure in the minutes it either recorded as an abstention or an objection to it, solely on the basis of the way it's come to us. And there's no explanation of why it needs to be a memorandum of understanding, to be honest. So I said I'm not going to agree to it here today, because it's the same boat. I mean, it was in the papers, but we were in the same boat, trying to force an agreement from that board. I was the only one who objected, by the way.
Okay. Councillor Watkins, and then I'm actually going to move something, so we at least...
Yeah, I was just going to recommend that you deal with it at the next meeting, which will be in time for Barry to take it back anyway, so that was my recommendation.
That's what I was going to put forward, so I'll second that it's an item for the next meeting of this scrutiny panel.
I'll put that back and tell them to wait for our response.
We'll see if that's agreed. All those in favour of that? Okay. So that'll be an agenda item for our next panel meeting. That'll give a chance for the chair to...
Can I also mention this is out now, brand spanking new. There will be an electronic copy coming out, and there is a short video which I'm hoping to convince the Mayor and the officers that we might be able to show at the next council next week. It's only about 3 or 4 minutes, but it goes through that. It's an excellent document if you want to get hold of it. There will be a link to it. It's worth reading.
Can you just tell me what it's called?
It's called Everyone in Warwickshire Counting Counts, Valuing and Vulnerable. It's the Director of Public Health Annual Report. If it all comes to fruition as well, it'll be good. And if I can pray on your good offices, Mr. Chair, found out today that the STP, first thing I've ever found out since last December, is actually got a work programme for the primary care. That's GPs. They've actually got one and they're doing it. And also one on planning development. So we know that the STP has been operating. The first time there was a big complaint yesterday that it's going on. I should have said I made the complaint, but it got support at the end of the day. But we don't know anything that's going on with the STP, not telling us anything at all. But now we've got 2 little snippets of information.
Okay, well, that's useful because item 12 is the chair's update on the STP. But unfortunately, the chair's not here. I don't know
We
whether
didn't have anything.
But
So
which is even the chief executives of the councils are complaining now. Even the meetings they go to, they don't get any information on that.
Okay.
There was a brief update yesterday which told us absolutely nothing.
Okay. Well, we'll note that when we get to that item anyway.
Thank you for your indulgence.
Okay, thank you.
Thank you. I'm trying not to do that again.
Right. Thank you. I think that puts us back on track then. Item number 6, the redesign and improvement of stroke services.
Thank you, Chair. The first apologies for not coming to the last meeting, which you had the report that you've got attached here. I was supposed to come and present, and then because of personal circumstances didn't get here, so apologies for that. What was really heartening to see was that, again, the panel responded to the queries and questions and gave us some really good feedback that we've included in the engagement process. So just to update people, and again, because people live busy lives between one meeting and another, the proposals have been developed since 2014 with public patient involvement, with a member of the Stroke Association on our design board, our project board, working with the providers of care across the system to come out with the proposals that you see within the document that we wanted to share and start some discussions with local people on. So we'd had an original proposal that just looked at hospital services, but the feedback from that engagement said we needed to look much broader and deal with the rehabilitation, because we got gaps in rehabilitation services that people said no point doing the specialist stuff if you haven't got the specialist rehab. So we took some more time to develop the rehab options which were in the document. We also added into the programme of work around stopping stroke, so prevention. And again, the proposals are to change medication for those who have a particular heart flutter, atrial fibrillation, and make sure that people get optimum medication for that circumstance. And we know we've got some gaps in that at the moment. So from the review we did, we said, okay, we'll look at this. Yes, actually, there are some gaps and improvements we can make, so that's included too. The engagement time frame was for 6 weeks from the 15th of June through to the 28th of July. We had 4 public meetings originally planned, and we ended up doing 5 because we got early feedback that one of the centres for engagement wasn't good for the public meeting and some people couldn't access it. So we added on an extra meeting in Coventry because of that issue, and we extended the engagement period by an extra week so that we could run that event and then allow people to make comments. We're just going through compiling all the evidence, the information that we've got from the engagement, but we had 343 responses back. And again, what I felt might be helpful would be to give you some initial feedback in terms of the themes that came out of the committee. So if that's reasonable, Chair, some of the key challenges that you expressed were around transport and access. And the points were around public surface transport to UHCW, which in the document is proposed as the hyperacute and acute service going forward. So that's for when you first have your stroke, you'd go to UHCW. But also if you then needed, after your assessment in the very, very specialist unit, you needed some care in hospital, the main centre for that would be UH. So public transport to UH and also car parking capacity came out as I guess we'd expect, and has come through many comments actually. So both of those things we are currently looking at, so what could we potentially do about it? Part of your critique back to us, and again, very reasonable critique, was we said the first part of our discussions with the public had raised transport issues, but what we hadn't done in the engagement document was tell you enough about what we were then going to propose to try and mitigate any of those issues and or how we'd respond and deal with those. So at the moment what we're doing around transport is we have a group that's working with the transport providers that both county and City Council in Coventry. We've also are talking to the Combined Authority, who are developing a policy on transport for vulnerable people, which obviously would be beyond this group, but I'm meeting with them on the 19th of September to see actually what's their policy going to look like. And I think there is a broader aspect of actually how do we get better support for people to travel around who actually don't have a car and who haven't got, our public transport actually doesn't work for them. So we're going to look at this strategically, and we'll start and see what that policy is going to do for vulnerable people. But then also we will come out with a response before we go any further forward about what the offer might be around supporting people with transport, what we can and can't do. That doesn't mean, and just to be really clear, we're going to come out with an option that says, and we'll support this and pay for it and do whatever. What I'm saying is we're looking at all the options at the moment, and we will need to, before we go any further with the scheme, to come out with some answers to the questions around transport and access. So we are working on that at the moment. The other issue you picked up was around the rehabilitation beds. So in our proposals, we talked about wherever possible, and it's probably 70% of people, after they've had their acute episode, will go home, and our proposals are to provide rehabilitation for them at home. However, there are a small percentage who are more complex. They may have had a more dense stroke, they may have had a stroke on top of other medical conditions that they've got. So they will need a bit longer in terms of rehabilitation. And the proposals talked about having a ward at the George Eliot site and then one in Leamington. One of your concerns was again about people potentially having to go to Leamington from this area. And you wanted assurance that in our planning we'd actually planned enough beds at the George Eliot Hospital site. Our evidence and the information we've looked at suggests that there will be the right number of beds in this site for those people with complex needs to be located here. So our expectation isn't that they would go to Leamington. I have to say that some people actually at the moment do go to Leamington, but not to this bedded rehab. They go to a very specialist rehab service. We do have some younger strokes that transfer from George Eliot to Leamington. So again, that would still carry on because the only specialist rehabilitation, and it's very, very specialist, is in that rehabilitation hospital there. So I would hope that we can, and I'm not sure how you'd like us to respond, but we can respond individually on each of them. But we will know more once we've done our extra bit of work at looking at what the options are. So be happy to write back and confirm actions on each of those, Chair, when I've got them all sorted. So yes, you're quite clearly inadequate response to what we're doing on transport, and we need to do better. So we are working on that, and I will be able to come with something much more detailed so that we can look at are we then ready to consult, because we can address some of the concerns and issues, and it feels like a reasonable way forward. The other aspect you mentioned was around bed capacity and the loss of beds across the system. Because in the proposals we do have and you've mentioned a 12% bed capacity loss in the letter that we received. So I think the new model is such that we will need less hospital beds because people will be going home with rehabilitation earlier. At the moment we have no proper stroke rehabilitation service in this area. And that was one of the gaps we identified in terms of starting the work and doing the work. In this model we have, and we need to quantify the number of rehab beds or services at home, and you've been specific in your response on that, so we will get the details in terms of the number of packages of care at home, so that you can do the comparison of we'll still have this many beds, but also we'll have this many additional packages of care. That, I think, would allow you a better comparison to look at, have we got this right or wrong. I think the other bit for me about the bed capacity issue was some concerns from some areas that actually there's no point just switching the whole of this service on day one. You need to prove that you can deliver the rehabilitation before then you'd actually say, can you operate it in less beds? And again, what we didn't confirm in the document, because we've done some of the thinking, but obviously not all the planning, because we haven't consulted yet, and this will be a formal consultation when we get there. Our thoughts are at the moment in terms of implementation is that we'd want to build the rehabilitation services first, before we then put the system in terms of the change in the beds at the acute hospital. So I would hope, again, in any future correspondence, we need to be really clear about that, because I think some people are concerned that you need to prove you're doing it and it'll work if we can then accept the reduction in beds. But that's the same from our hospital providers and our doctors and nurses as it is from yourselves. So apologies that wasn't clear in the document, but I think we can offer you some confidence around that, and we can talk a bit more about that when we get to a consultation stage so that everybody can be clear. The final questions that you raised were around staffing and services, and you've described in here some issues regarding overall loss of staff from George Eliot. Because we were talking about the acute service and there being a networked service across all of Coventry and Warwickshire to make the best use of the highly specialist professionals that we've got in our area, and a national shortage of some of those doctors and nurses as it's starting. So I think the key thing to say is our expectation is that this will take more staff than losing staff. So our expectation, our hope would be that actually we don't lose any stroke nurses from the George Eliot, and certainly they would be helping us with the bedded ward. We've currently got an outreach service, a therapy outreach service for stroke at George Eliot, which is the only bit of therapy that we've got. It's not the right model yet, but they do their best at the moment. But again, those therapists and more will be needed in this model. So what we know actually is that we've got quite a workforce challenge in terms of trying to get the number of staff to do this. So it won't be a loss of staff, it will be that we need more staff. And that's as much of a challenge as it is the opportunity, I think, to get this right. So there was then a concern about could that then result in a de-skilling of staff and maybe make more services vulnerable. So one of the pieces of work that we do need to do is a bit more work on what the impact of the changes would be. And I think people have brought it out through this engagement piece. But also we've recognised we were about to go to a next stage of our assurance process to say, are we ready to consult? And we've actually slowed that down because actually we need to do a bit more work on the impacts for local providers and hospitals, and just make sure that actually we could get full support from each of our providers before we then take that next step and try and get to a consultation stage. So, and you also criticised some of our case studies as not being very balanced. I apologise for that. Our public and patient group that have been involved with us actually did the case stories, and they're real in terms of the scenarios that people have faced. They actually wrote them with us. But obviously what you're then, I think the bit where you're thinking they're not very balanced is that obviously everybody has a good outcome, don't they? So I guess that perhaps isn't a good balance in terms of an end point. But we did spend quite a bit of time with the patient and public group to try and get that right, and the Stroke Association who chair that group. But we will think about that in terms of our next, the public consultation, which again does need to be a very balanced document, I think. So all of that is really helpful for us in terms of clarity about what your concerns are. We will be, as I say, doing some more work to look at all of the concerns and come out with, when we are at the next stage, a more detailed plan. And I'd be happy to come back, if it takes us a little while to get to that, I'd be happy to come back should the panel wish to give you an update in terms of where we are maybe in a couple of months, or because I would hope that we'd be saying actually we've got through all of this, we've sorted it all out, and we think we are ready now to go to a consultation. However, as we know with a stroke project, it seems to just go on and on and on. We never quite get to that final hurdle, do we, for one reason or another. So, but I'd be pleased to come back, Chair, should people want me to do that.
Okay, yeah, that'd be appreciated. Thank you. Anybody want to make any comments? Councillor Wilson.
Thank you, Chair. You mentioned that when you're looking to go to consultation stage,
Yes.
would you be envisaging there to be events for people to come to for consultation events? In that case, just looking at Appendix B, which is your poster advertising your previous ones, one of the things which strikes out at me is that all the times are during working hours.
Yes.
Whilst strokes have the perception of always hitting the elder generation, which do tend to be retired, strokes can affect anyone at any age.
Yes.
And also the people who end up caring for people with
Yes.
strokes
Yeah.
tend to be those who are working age as well.
Yeah.
I think one of the things that needs to happen is that there needs to be some out of working hours
Yes.
consultation events
Okay.
to enable that. And I noticed that there was one in Bedworth. Was the additional one you put on in Nuneaton?
No, it was actually in Coventry, so we did another one. It was the Coventry area that said we couldn't get access to the sites.
I would ask then in that case that we look at putting one in Bedworth and one in Nuneaton,
Yeah,
so that it's fairer to all the residents in the borough.
yeah. I think
That's all I had, Chair.
yes, no, that's again, that's really helpful, because I think the working hours bit is important, isn't it?
No, I appreciate that because it's a good point to make about. I know whatever times you arrange for anything, it doesn't suit everybody. But
Is there a time of an evening that people think is like this meeting's at 5 o'clock? Would 5 o'clock be okay, or would it be 6 or 7 o'clock? Have you got any experience from the council, the borough, in terms of how what's a good time to get people on?
I would have thought 6 o'clock
6.
would probably be better than 5 for working people.
Yes, to get home and.
Because some don't finish till 5, they've then got to travel. And
Okay, so 6 would be reasonable then in terms of an evening. We'll make sure in the consultation that we do that.
yeah,
Thank you, Chair.
hopefully in Bedworth it will be somewhere central.
Yes, we've used actually, we tend to use the town hall in Bedworth, not the town hall, the venue, the civic hall, yes.
Yeah.
And again, we did use that this time, but we just didn't get that many people. But again,
No,
maybe,
yes.
as you say, working hours.
Okay. Is anybody? Yeah, Councillor Elliott.
Thank you, Chair. We talked about organising transport for vulnerable people.
The policy, yes.
Looking at this, it implies that patients wouldn't be in Coventry University Hospital for more than 2 or 3 days.
Oh, that's not correct.
That's
They'll be there for. So there's a. Sorry, the report's potentially confusing. So for the first phase of stroke, within the first 3 days, they can be in the hyperacute bit, but they'll then have a follow-on care. So the average length of stay that we're looking at here is about 11 days.
And then transferred.
And then transferred
Okay.
for the majority home, but for that small percentage back to the ward-based care at George Eliot, it will be for local people.
So you're looking at transport options for vulnerable people. Just wondering what your definition is of vulnerable people.
Again, there's a broad definition of vulnerability, isn't there, around a whole raft of things in terms of people's ability to participate in society. So what I would like to do is, when I mentioned vulnerable, and actually the Director of Public Health report that Councillor Longdon mentioned earlier has got a definition of vulnerable in terms of what they mean, and that says, you know, it can be everything and anything. But so certain factors, inequalities, can create vulnerability, as well as the lifestyle issues and also economic issues. So in terms of the policy development for transport for vulnerable people, I've got a meeting on Tuesday the 19th with the lead from the Combined Authority who's developing that policy, and I'll get some of that information then in terms of who they mean as vulnerable, because I've talked to them about stroke survivors as fitting that category, and they said yes, and their carers is the other bit for me. So a lot of the transport issues actually will be for those caring for those who stroke. So for instance, if you're in UH and you've got to travel from here, then it's actually about those transport issues if it's 1 or 2 buses or more for others. And we've got the same from the other areas, they've got minor issues. So I'll get that definition and include that if I can next time in terms of what that policy covers, because I guess it's that bit that you're particularly interested in. So I'll get the definition from the Combined Authority on the transport policy for vulnerable people.
Thank you. Councillor Smith.
Yeah, I was really just going to comment on, thank you for that very good report back on some of the things you raised. It was quite detailed, and it did answer a lot of things we raised at the last meeting, which was good. One of the things we did pick up was that shortage of beds, that reduction in beds.
Yes.
And I think that may rely on the success of the pilot home scheme. Are you open to reviewing that reduction of beds once the results of the pilot scheme come through?
We're continuing to look at how it's working, and what we will do is put the we continue to monitor what the demands are on the services, as they change year on year. And as the project's gone on, we've had to, part of the challenge we have is we have to update it then for all the data and evidence we've got from the previous year. So we do continue to review. If the bed status changes and we need more beds, then obviously we'll need to look at how we could do that. So that potentially could change, well, it'll change the financing of the model and the staffing of the model, and so it would just give us a bit more delay if that happens. But we are continuing to keep under review the modelling we've done to say, is this realistic?
Yeah.
It's the piloting work we did in Coventry around an early supported discharge, so starting that bit of work off, actually has had more people than we thought able to go into the service. So our original intention was that we'd get about 40% of people home with early supported discharge, because that's what's happened in other areas. However, for some reason in Coventry, they've got an awful lot more than that, the 60% who've got home. But we think they're probably not applying the criteria correctly, and they're taking other people home for where we've got a gap in other services. So we do continue to do that as we go through. And we'll have to demonstrate that when we go through this final check with NHS England as well. So.
Good.
Okay.
Okay, Ms. Kubish.
Thank you. Thank you, Chair. Just as an add-on to Councillor Smith's comments about the bed situation, has it been considered about the social aspects? Because if you want to send people home for rehabilitation, if they live on their own, they're in a second floor flat without a lift, then they can't be rehabilitated at home, and therefore they will need to go into George Eliot Hospital. So has that been part of the consideration?
Yes, in terms of considering the number of beds required, the bedded rehab offer, we looked first and foremost at what we think the percentage who will be these complex and need more care, and we've also looked at some of the social circumstances that potentially will cause a delay. So there should be enough capacity in there from the modelling that we've done. As we've said, we'll keep it under review, but our sense is that that should be adequate to include both of those. Some people may go to the George Eliot site, into that rehabilitation facility, and then a decision be made quite quickly. Actually, this lady or gentleman actually need a longer term and continuing health care and or other packages of care, or care in a care home. But what we wouldn't do is make that decision at UH, because generally people need a bit longer for assessment. So the capacity is to include those individuals as well in terms of what's presenting and being managed at the moment. So.
And with the rehabilitation at home,
Yes.
who will be doing that rehabilitation work? Will that be district nurses?
Therapy-led mainly, so it'll be therapists and the nursing teams. There will be a specialist group in terms of providers who come in and do that. They will be our local providers though, so it will be about expanding the local services to do that. So again, they'll be integrated with the others, but very specialist to stroke. And one of the big issues, we want this stroke service, when we get there, if we ever get there, we want this stroke service to feel a really great place to work as an individual for stroke, so that we're not leaking and losing the staff, and that they are staying. And at the moment, part of the challenges that they've expressed is the discontinuity once you get a handover of people. But for stroke, the evidence is if you can create a really good networked service, that it doesn't matter if you work in a hospital or in somebody's home, you all feel part of the team. That will be a really good way for us to keep the staff but also provide a great service. So we haven't got that as well as we need to do yet. This should give us an opportunity to do it.
Thank you.
Councillors?
I've got several questions, if that's all right. One is about your staffing and services. I'm just wondering how you're advertising that you're looking for staff.
Yeah.
Because last time that I was at an health meeting, we had somebody along who said that there's a shortage of staff within the country and we'll be looking at the Philippines.
Yeah.
I've never seen an advert for staff at George Eliot.
Right, okay.
And if I get it on Facebook or whatever, I'll reshare it. never seen one for George Eliot.
Oh, right, okay.
Okay.
Well, I can certainly describe that we're actually not at this stage until we've consulted to be in a position to start the recruitment. So we're a little bit off that for the moment. I know that my evidence, and I don't know whether Gordon wants to come in.
I mean, we are fully staffed at the moment
Yeah.
for the patients we've got.
Yeah.
But as Andrea says, these staff are very, very short in supply. As we expand it, that will be the challenge then, to actually get people to fill up more spots. But at the moment, we've got a fully staffed service. So, but as it expands, and I don't know what the modelling is in terms of staff for doing care at home, whether you actually need more.
Therapy, yeah, we
Probably do need more to put in
yeah.
if it's at people's home. Then that will be the challenge, won't
Yeah,
it?
it will. The therapist will be the key one, I think.
Well, like I say, I've never seen anything advertised ever for George Eliot. The other one would be, would if any of them were council tenants that you work with the local authority, because as far as I know, we still have not got any discharge policy. So they could. So although we was talking,
Yeah, we talked years ago about this.
It's got to be 5 years ago, I think.
Yeah.
Got to be. Still not got that. That's still not in place. So you could still discharge people to our housing stock, and it not be fit for purpose.
And I know, councillor, there was work definitely started on that, so it's a real shame if that hasn't been well, it sounds like it hasn't been followed through, but we'll check into that.
The other one would be, you got specialist rehab beds at Leamington. Can
Yes.
you tell us a little bit more about that, please? And
Yes.
we'll kind of have something similar in this borough.
So the beds that you'll get at Leamington will be the same as the George Eliot one for this proposal. So the specialist rehabilitation hospital that's at Leamington is for really quite complex rehabilitation, neuro brain injuries. You really don't need that many nationally. Leamington is one probably in the whole of the Midlands in terms of serving a population. So, and the challenge always with those really specialist services is that in order to keep the skills up as a professional operating in that environment and or any environment, you need to see and treat and work with enough patients, you know, the throughput, if you excuse the language, but the number of patients you see and treat needs to be enough to keep skills and competencies and development in place. So that scaling of that rehabilitation hospital is on the basis that the people who go through there will allow the teams who are providing the service to provide the right level of care, maintain their skills and competencies, and with the very best of rehab. So they take you know, significant trauma cases who need an awful lot of rehabilitation. So they are very, very specialist rehab.
So
on the other elements, it's just we're using one of their wards for the stroke rehab.
Right, okay.
Does that explain?
Well,
A bit.
it explains that we've got a neuro brain one at Leamington, we've got one in the borough, that's what it explains. I'm still shocked that you're shocked that we're still talking about transport, because every meeting I've ever been to is always about transport and the fact that we live in deprived areas within this borough and couldn't afford to go to Coventry. But my last point really would be on bed capacity. So we used to have the Manor Hospital, Bramcote Hospital, and we've got George Eliot Hospital. We had less people living within the borough then, when we had 3 hospitals. We've now reducing bed capacity and increasing population. The maths don't really add up, so I'd like somebody to try and explain that to me. Now we can go from 3 hospitals to 1, reduce and increase the population.
Okay. So I can't necessarily do the 3 hospitals into one. What I can do is assure you around the ward, the beds that will close at George Eliot, the stroke ward, the acute stroke ward, will be redelivered as a rehabilitation ward. So there won't be a loss of beds at the hospital. So there isn't, the plan doesn't do that. That was one of the reasons. At the moment, what happens with the stroke ward at the George Eliot is patients will go in when they first had their stroke, not if they're assessed against a particular criteria for up to 4 to 6 hours of having their stroke, but other stroke patients are pulled through and managed in those stroke beds. There's 19 beds in total, 1 assessment and 18 others. In our future model, we talk about having 20 beds, so there isn't, in effect, it's almost a like for like. The difference will be that the care delivered in those beds will be different. So just dealing with that and this issue, there won't be a reduction in beds, and we will be reusing those beds for this rehabilitation service. So changing the service delivery, but keeping that local. So, and that is on the basis of the number of people who are stroking and who are forecast to stroke going forward.
So that's taking into account today's population and taking into account the increase with
Yes.
new houses.
We will, yes, we've included within our plans, we always do the demographic look forward for the next 5 to 10 years. We've done 5 years planning in terms of the numbers. As your colleague mentioned earlier, where things change, we will have to make some changes. So, but it could be, I mean, one of the things that's potentially is difficult to get is actually getting these services right will be that people do need less acute beds, because at the moment we know we've got people in beds that George Eliot teams know would like to go home, but we haven't got a rehabilitation service for them at home. So they do end up staying in an acute hospital, and that's not good for people. You know, it can actually increase the frailty. It can increase, mean that they lose some confidence. So with this model, it's been implemented elsewhere, so there's evidence that actually it's a really good model of care. So it should give us a much better outcomes and opportunities for people. The savings that you get in doing this model are really in social care, because dependencies after the stroke are reduced, because you're getting that rehab offer right at the right time and the right intensity and expertise. So.
That's been done, Chair.
Okay. Yeah, I mean, the issue about care at home is a really important one, because I think most people would prefer to be at home.
Yes.
But the support package has to be there.
Yes. Yeah.
And we've seen on a number of occasions where that's failed.
Yes.
And so we would want to, be sure that that's in
Yes.
place. But I've got a couple of comments and questions myself, and I'm not going to apologise for repeating something that's already been said, because one of my old chestnuts, and it goes back further than
5 years.
Councillor Watkins, going back to the old Community Health Council days,
All right.
is about the travel issue.
Yes.
And my view on it is the person that's needing treatment doesn't really worry too much about where they're going, because they just need the treatment.
Yes.
But as well as the hospital support, you need the support of family and friends and that. And it's incredibly difficult for anybody from Bedworth and Nuneaton to get to Walsgrave.
Yes.
But you do need that support. So I know you've got to do a bit more work on that, see where we're going with it.
Yeah.
Because I was going to ask the same question about the description of vulnerability.
Vulnerable, yes. Yeah.
And I think vulnerable should include that aspect of,
It should.
of the economic aspect, that people can not only not afford to get there if they haven't got their own car or anything, but it's the time out of your day and your life is, to go from here to Walsgrave, at least 2 buses and probably a couple of hours journey. It's really difficult, but you're looking at that, and that's fair enough. I'm interested in, and this is probably my ignorance, about the rehabilitation. And I'm just thinking from a personal perspective, because I've actually 2 visits this week to take somebody to Sally Oak for rehabilitation.
Yes.
And
so that's another very, very specialist service, neuro.
yes, I'm just wondering why they have to go all the way there. You've got something at Leamington, unless it's a totally different.
They are different. There are a range of rehabilitation services, and that will be a very specialist one.
And I mean, it's a similar thing. That person couldn't get there because the severity of his stroke means he can't drive, and his wife doesn't drive. So I take them.
Yes.
But it's like twice this week. Couldn't get 2 appointments on the same day, like they normally do.
Yeah.
So it's 2 different visits.
Well,
And
those.
it's a long journey. Really.
So those sort of things around, if we can make it more sensible and organised, particularly if people are travelling, try and get, if they have got 2 appointments, that you could try and sequence them together. Those are things we could try and do something about as well in terms of commissioning.
They do normally.
Oh,
they
right,
they do
okay.
normally. For
It
some
was just,
reason, this way they
okay,
couldn't.
it was a
so,
problem. Right.
Yeah.
I mean, just as a more general note, I'm afraid there is a trade-off here, isn't there? Because it applies to our cancer patients as well. You know, they need complex cancer surgery. They've got to go to UHCW if they need PCI for their heart attacks. So you know, if you're going to get the best service, unfortunately, the realities are now it has to be centralised. And we've always said what we can deliver locally, we will do that.
Yeah.
But we're not giving people the best treatment if we try and do that here. And that's a big trade-off. We can try and help with the transport, but we can't offer what they can offer at UHCW here. That's the difficulty.
Yeah. Again, my own personal view has always been and remains that wherever possible, services should be provided locally.
Absolutely agree with that.
And the concern of local people is what they see as the diminishing services at
Yes.
But then you've also got to balance that by saying your outcome's not going to be as good if you don't get that central service. That's the trade-off.
But over the years, we've seen it with the going back to back to the Falklands days when the Elliot used to do the skin, the specialists in what you call it,
Plastics.
plastic surgery.
Yes.
That got taken to Walsgrave. Different bits and pieces slip away. I accept there's an argument about the speciality.
But, I mean, just to, and Andrea knows about this. We are now doing some angiograms at the George Eliot, which we've brought back.
Yes.
Because we can deliver that now locally, so that's bringing it back from Coventry.
Yes.
It's 2 ways, because we can do more things now locally that couldn't do in the past. So I mean, we just keep that going. I think
one of the important things we need to get better at is talking to people about some of these issues, because I think that generally when you do talk to people and spend a bit of time, people get it that you can't have everything local, but if you can have the best outcome, the right quality, and as Gordon has said, there is a bit of with our networked service, which is what the trust do with UH on the cardiac surgery. You can then be safe to do something local that previously you may not have
to be done in Coventry. That's right.
So it's trying to get that over without saying to people this is about cuts and rationalising, because I think that's the concern, isn't it? It's about less rather than it's the right quality, and some of it's more actually.
I don't mean, certainly as councillors we probably tend to be critical about things, but equally when there's good news, it's also quite difficult to get that message out.
I know. We need to do better on that.
Reluctant to report on good news rather than bad news.
If I can just say, as a 15-year survivor of throat cancer, I concur with everything you say about local services, but I know when I was in critical care, I wanted the best care, I didn't care where it came from. And when you're in that position of a serious stroke or a serious cancer, you don't care if people can't visit, you just want to live.
Yes.
And if you can offer that best service, I think that is primary important.
And I think, South Warwickshire, I spoke to the medical director, they've got a bigger challenge. They've got huge areas, very outlying districts, real travel problems. They're brought up even worse than I think that we've got.
Some prefer to go over to Worcestershire.
That's right.
Well, okay, thanks
that
very
all
much.
right?
And I know you'll keep us updated
I will.
on those things. So we're happy to note those things. Okay, thank you.
Would you excuse me, Chair?
Yeah, of course you can,
Thank you. Cheers.
Okay, if we can move on to Dr. Wood yourself.
Okay, thank you.
End of life care report.
Can I sit here in? Or do you want to, can I come and press the
You'll
buttons?
have to come and press
I'll press the buttons.
I hoped I'd got a figure for you, but
This will be very brief. I think we're 6-5, so...
Light brief. Is that this one?
So I wasn't quite sure of the brief, so I just thought I'd do what's happening locally about end of life, if that's okay.
That's it. Thank you. So let's press the forward button. Okay, so thanks for the opportunity. I just really wanted to give some definitions first of all, because I think there's a lot of confusion about end of life and palliative care, and the two are slightly different, because I think everybody in healthcare, and I think that includes residential homes and nursing homes and the community and GPs, have all got a part to play in end of life care. It's not just hospital, it's not just palliative care, because lots of patients are dying and they need that input wherever they are, not just in hospital. And so I think all healthcare staff should have that skill, and that's something we need to develop, definitely. What palliative care is, it's slightly different, because it's, first of all, it's people with progressive life-limiting illness, and that doesn't just mean cancer. And we know, for example, people with severe dementia, with severe liver disease, with bad heart failure, with bad lung problems like bronchitis. Some of those have got a worse outlook than cancer patients. 50% of them could be dead within a year. So it's not just cancer, it's any life-limiting illness, of which there are many. But the palliative care team come in, where in the normal care that they're getting, whether that's in a nursing home or in hospital, despite the best efforts of their team, those complex needs cannot be met. So for example, it could be pain control, it could be vomiting, it could be other symptoms that are very difficult to manage. And that's where palliative care comes in, and that's where you need the experts in that field to actually put in their input. So the two are slightly different. Now, you'll be aware that we've got a real dearth of resources up here. We've got no local hospice beds. We've talked about the difficulties of getting to Coventry. Myton is our nearest hospice. I think people find it very difficult to go down there. They don't feel a connection with it. It's across the M6, big barrier. So we've not historically used even the local beds, the ones that we've got in Coventry, very well. And we have got no beds in the community locally here. What we also know is that there are more people in North Warwickshire and Nuneaton who die at home or in hospital rather than nursing homes or hospice, and I'll show you a slide on this in a minute, but historically that's been the case. So people do tend to end up more die in hospital than elsewhere. And just as a reflection of that, if you look at the percentage of deaths in admissions, so for every 100 admissions we have to the George Eliot, 5.5% of those admissions that come in are going to die in the hospital. Now, in the West Midlands, it's 3.7%. I think we were the highest in the West Midlands. I don't think that has anything to do with the quality of care. I don't think it's anything to do with the safety of the hospital. I think it's simply a reflection of the fact that we have a lot of patients who actually are end of life and end up coming into an acute hospital. And another factor, January this year, we had the highest palliative care coding in England. So we had more of our admissions who were coded or who were diagnosed as having end-of-life care than, again, in the rest of England. So a bit of a reflection on what there is outside. This is just a slide that actually came from the CCG, and what this shows is, if you look at, this is for England, so these are the percentage of patients in the community who are dying in hospital. So nationally, in 2004, about just under 60% of people were dying in hospital, and that's gradually decreased. Now this is North Warwickshire. So you can see there's a big gap here. We've always had more deaths in hospital than out of hospital. And although we're coming down with the national trend, we still have more hospital deaths than patients actually dying at home. So, as I said, often deaths occur in the George Eliot. I think part of that may be patient choice, but I think also part of it reflects a lack of alternatives. I remember Bramcote very well. I used to work there. Bramcote's gone, we've got no hospice. There's not a huge amount of support, I think, at the moment in the community. So unfortunately, the default position is, even though people may want to die at home, often it's not possible, and circumstances force them to come in. It may not be the place they want to be, but that's where they end up. And even now, we've got a lot of patients coming in from nursing homes. I look at every single death every week with our coding team, and time again we're seeing people with very advanced disease. They've already got do not resuscitate decisions with them. They come in with a form. Actually, you know, it's clear that they are at the end of their lives, but they're still being admitted. And I don't think that's the right thing, you know, because we can't really do anything for them. Often it's the last few hours they spend in hospital, and I don't think that's the right thing that we should be doing with patients. We shouldn't be making those last minute admissions for no real benefit to them. Now, we've had problems in that we lost our only palliative care consultant in December last year. We've been actively trying to recruit. I think what we've realised is that in future we're going to need 2 consultants, because one of the issues was the consultant found it very difficult being single-handed. So we're going out for 2 consultants. We've advertised, we've not had any applications, but we've got probably a couple of people we know about now who may be interested, so we are actively trying to recruit them. About the same time we lost our palliative care lead nurse, and again we're actively going out to recruit, but I'd point out there is a national shortfall. In Coventry, much bigger hospital than we are, have got about 1.5 consultants, and South Warwickshire at the moment haven't got any consultants there either, so it's a really difficult situation to recruit nationally. So what's being done, and the CCG are working on this, is to really try and get more community support. And what we're going to try and do as a pilot is hospice at home. Now that's going to be run by Swift and by Mary Ann Evans as a joint project. And their aim is to recruit staff. They're aiming to be able to respond within 2 hours to any patient who has got end-of-life care needs, to get that immediate response. Because often if you can step in at that point, you know, you can keep people at home in the crisis and mean they don't have to be admitted to hospital. There's all the other things about West Midlands Ambulance, able to flag up end-of-life patients, having a register of patients that we know who are reaching the end of their lives, so the community are aware of what may need to happen to them. There's a look at community beds in nursing homes, possibly looking at 4 beds that we could use as like a hospice provision, so they would be in a nursing home rather than a hospice as such, to see whether we could use those for patients who've got complex needs. But I'm absolutely sure that we need better staff training. We need to be in with the nursing homes to, I think, increase their confidence about dealing with people who are reaching the end of their lives, so that the care can be provided there rather than having to admit them. And we're hoping that we can also increase referrals to Mike. Now that is actually beginning to happen, but I think a big help in that will be if we can get a consultant who can liaise with Mike and take the patients over. I think local people will be much more happy to go over there for their, let's say, if they've got complex needs, to try and improve things. So I think there's a lot to be done. I do think we're under-provided, and I think the figures we've got in terms of palliative care and admissions to the hospital kind of back that up. And it's certainly something that we talked to the CCG a lot about, is getting that home provision better. So I'm happy to take any questions or any points that would like to raise.
Any comments or questions? If I know it's, you know, there are areas of difficulty in recruitment and various things, but particularly in this, do you see it as maybe the perception that people have had about it, particularly the dual gamut with the, you know, because when you read when the reports come out about high rates of death, we know that can be related to traditional, you know, the types of industries we've had in the area, and things like that, and the deprivation. But I don't know whether you would see it as that perception is maybe holding people back from recruitment.
No, I don't think so. And in fact, our mortality rates now, we're just expecting the CQC in the next couple of weeks. I can tell you, both our mortality markers are absolutely within normal limits. So the 2 numbers that we use are both absolutely fine. So it was high, but it's come right down now. And in fact, we've got a consultant I've just spoken to who's working in Manchester, who's moving down to the area. I think she's very, very keen to come and work with us. So we are actively, you know, we're not just sitting back, we're actually recruiting people, we're trying to talk to people we think might be interested. There's another consultant I know who lives locally. We're doing our utmost to try and, you know, encourage them to come. And I don't think they see this as a problem. I think this actually is a great opportunity, you know, to work around here.
Okay, thank you. Councillor Elliott.
Thank you, Chair. The last point on the slide, the last bullet point says increase referrals to Nuneaton. A couple of years ago, my dad died in University Hospital. He was there for 2 weeks. He was there, he was dying. And we tried everything to get him into hospice, or to get him somewhere. He didn't want to be in that ward. And we were told that you only get the last day of your life in Nuneaton. He died in hospital.
Right.
So is that incorrect?
That certainly wouldn't be the aim of it, because Nuneaton, really, it would be a facility where people with complex needs, for example, need pain control or they need symptom control. The aim of admission there will be to try and get those things, and then with a view to getting people home if possible. So there was certainly no view that it had to be the last day of life, absolutely not. And I don't think many hospices would work on that way. But unfortunately, it is the only inpatient facility really we've got much access to.
They just said there wasn't room, so that they
Right.
had space for...
And I mean, I still think there's a lot to be done in getting people, if you ask people, it's something like 80% if they had a choice would prefer to die at home. But we don't make that possible for them, do we? Because there's not the support there, there's not the pain control. If they run out of drugs or if their pain is not controlled, then it usually means hospital admission. And I think part of that rapid response team is really to try and support people if possible, to keep them in their own homes if that's what they want. Not possible for everybody, but I think there's more we need to do. It's not just hospice beds.
So sorry, the question was, there is room in Nuneaton, there's space available for people, because it just sounded like there wasn't even space for Coventry.
I could certainly try and find out what their occupancy rates are, but we actually have much less access. Well, we use less beds there than we should be in terms of the numbers we should be referring over. And I think we still need to look at what we can do locally. You know, I would rather have something in North Warwickshire if we could. We're even talking about, you know, we're trying to look at the health campus model. I would like to see 4 beds actually on the George Eliot site that were for end-of-life care or for palliative care. That would be my ideal.
Okay, thank you. Mrs. Clemesh.
Thank you. You said about that many are admitted from nursing homes with do not resuscitate decisions.
Yeah.
At what point in time are they coming into George Eliot Hospital? Because if somebody has taken a downward turn in a nursing home, it's not dignified for them to be shipped out to George Eliot Hospital in the last few hours of their life.
Absolutely agree.
So...
And the problem is, and I think some of this is, there's a big turnover in nursing homes, particularly in staff. They're often not very well trained. Don't think they have the confidence to recognise or I think the other thing is, although a DNAR form is there, there's not been any discussion, and this needs to be done more, is what's the plan here? You know, is this patient to go into hospital, or should we really be delivering care at home? My parents both died in a nursing home, and I had to go and say, they don't want to be resuscitated, so please don't do that. I signed the forms. I said, please don't take them to hospital, because they don't want that. I had to get the local GP phoned, and we had to tell the ambulance service. When we did all that, they were not taken off. But I shouldn't have had to make that huge effort for a pointless intervention, and they were perfectly well looked after, and they died peacefully. But unfortunately, I think there's a big thing, they've got a chest infection or they're deteriorating. They may have a DNAR, so we won't resuscitate them, but we'll send them to hospital, because, what for? For a drip? For antibiotics? Well, it's futile. And I just think we need to get that planning better. So it's called advanced care planning, ACPs, so that the home care and the family and the patient are all aware of what we're going to do if we get to that stage. Unfortunately, people are coming in for the last few hours, and that's just totally wrong.
Yes. I mean, a nursing home is meant to offer nursing care.
Absolutely.
If it was a residential home, that would be different.
Yeah.
But
and it's like I was saying, I think all healthcare staff, not just hospital, should be able to offer end-of-life care. It's not just for hospital. some of it should be done in the community.
Is that anything that the clinical commissioning group could help with
Yes.
in terms of training in
Absolutely,
nursing homes?
and I went to the last CCG meeting, we had some very useful discussions, and there's in fact some booklets now for patients to start reading, start making those plans ahead. You don't want to do it at the last minute, obviously it needs thought, it needs discussion, and training home care staff, because they're not confident about doing this, but to start having those discussions about, you know, if things get worse, what shall we do, what would you want us to do? So there is a big training thing now, and hopefully we can get that moving. And I think some of the care staff they're putting in hopefully will facilitate that.
Thank you.
Councillor Margaret.
Thank you, Chair. First of all, can I begin by apologising? I've just come from another meeting. I got stuck with the train, so I apologise about that. So I'm sorry that I've missed the presentation, but I have seen previous presentations. I was just interested in your points in relation to hospice care and end-of-life care beds within the north. It's an issue that I'm quite passionate about. I brought it to this committee previously, and I just wondered what the George Eliot was doing or able to do to join us and others in putting pressure on the appropriate funding bodies to get something happening, both in a hospital bed sense, but also in end-of-life treatment at home.
Absolutely.
So I just wonder what we can do together.
We've been talking to the CCG, we realise it's a big gap, and just saying that we would be very keen if we could maybe get 4 beds, that's what we think we would need, on site at George Eliot, or the other talk about is a nursing home, but I think you'd need to be really sure that they are the correct beds in the right place before you did that. But no, I do think we don't need many inpatient beds, and it should be for complex needs, and I think more care at home is absolutely needed. So the rapid response team that are being set up is to try and deliver that. And the CCG are very aware of that and are putting moves in to get that better.
Okay, Councillor Wilson.
Thank you, Chair. I think in some ways it's quite disappointing we're still having to talk about this, because I remember not long after I was elected 7.5 years ago, myself and Councillor Watkins, we sat on the end-of-life care working party, and time after time these periodically come up at various committees I served on, and we don't seem to be getting anywhere, unfortunately. And one of the points that you made about staff training I think is absolutely critical. 15 years ago, and it still haunts me to this day, because it's a formative experience in your teams, watching your grandfather die, and time after time you watch your family repeatedly tell nurses and consultants what to do about various things with the person who's at their end of life, because their likes, dislikes, their confusions, etc. And either someone can't be bothered to write it on the notes, or someone can't be bothered to read the notes. And the frustration, not only the agony that causes to the patient, but also the distress it causes to the family. This is two-pronged, it's not just the patient, it's the family as well. So then, 13 years later, I'd hoped after all the work we'd done and seeing this go on, we'd have actually learned something and done something. How can it be justifiable? And I know that there are issues with nurses, but to see a 97-year-old woman who is doubled over with osteoarthritis, screaming in pain, you can't lie for that, she hasn't laid flat in 40 years. To see nurses try and force her down onto a bed, family screaming at you, why aren't we actually getting better at telling nurses and doctors, read the notes? Because I'm convinced that some of the issues towards end-of-life care, you're never going to solve the cause, but it's how you end with dignity that matters. And it annoys me where nurses, and there's whole campaigns about this, but you've got to get it right. There's rights and responsibilities. If you want the pay, you've got to do the job properly, because you start to lose the trust of the people. My family now, the minute you mention end-of-life care, they immediately dread anything to do with end-of-life care in George Eliot because of the experiences. And that's why you've got such a barrier with this community to get around. How much more training will you do with staff? Not just end-of-life care staff, but all staff.
So I mean, this is one of the works that we're doing. We're doing a study, or we're doing a survey of how people found end of life care, so we can learn from that. The other thing is that the Do Not Resuscitate form has now been replaced nationally by a form called Respect. That is much more specific about what is the plan here. Is this patient going to go to ITU? Have you had a communication discussion with the family and with the patient? That has to be logged now. You know, that's much more specific. So we need to get better at doing that planning. And you're absolutely right. I mean, I think unfortunately the problem is we try and do too much at that stage when the care should be to keep people comfortable. We're not going to save life. We're not going to make survival any longer. But it's dignity and having a comfortable death, isn't it? Absolutely agree with that. And we've still got work to do on that.
Okay. There's no other comment. We thank you for your,
Would you excuse me as well? I've got another thing I need to go to.
we thank you for your presentation and for your attendance. Thank you.
Can I just say, Chair, that I understand that Dr Wood's leaving George Eliot Hospital,
Well, I'm stepping down as medical director
and
at the end
somebody
of the
else
month.
is taking this role. Is that correct?
Yes, correct. Yeah.
So who would we be?
So Dr. Catherine Free, who is Deputy Medical Director at Leicester University Hospitals. Catherine Free will be taking over. For all of October, we'll be both working together. So if you contact me through October, I'll still be around. Okay, but Catherine Free will be taking over.
Right, so we like to see.
Somebody else.
Yeah.
Yes, okay.
Okay.
Well, we wish you all your best.
Thank you very much. I'll still be working in a reduced role. Thank you.
Okay, thank you for your patience. Sonia Johnson, to report on your work with the Healthy Living Network.
Thank you, Chair. Excuse me not being suited and booted. I've just come from the warehouse, so which I'm going to talk to you a little bit about tonight. The Healthy Living Network, for those who don't know, weren't here at the last meeting. We are about reducing health inequalities. Registered charity since 2013, but we've been around since 2003. We were set up to serve the area of Nuneaton and Bedworth originally. We now work outside the borough, but predominantly our work is still 80% within Nuneaton and Bedworth. And having talked about all of the primary and critical care and the end-of-life care, our work is all about prevention. And it's about trying to get people to change their lifestyles where we can and encourage healthier lifestyles in order to be able to get them to live longer, healthier lives, which can be very difficult in disadvantaged areas because there's lots of those wider determinants that influence people's health and lifestyle. And we were hearing more and more over the last sort of 18 months, 2 years, when we're talking to people on the streets and in community centres and in the areas of our work, and since we've had the big lottery funding, trying to concentrate more on families, that they've got massive barriers to healthier lifestyles. It's all very well as telling them, public health telling them that they need to be healthier, but they can't afford to be healthier because, being healthier costs money. And whether that's just a perception or whether that's a reality, we were hearing it more and more. So we started to dig a bit deeper into that. And these are not people necessarily who are on benefits. These are people who are earning. They're out at work, but they're finding it harder and harder. Public sector workers who've seen their pay frozen over the last X amount of years. So a long story short about how we got involved in this, because it's very messy and it's very raises lots of questions about things that have happened across the county. But we are now managing the food bank in North Warwickshire. The food bank was set up by Ocado and North Warwickshire Borough Council, and it was set up completely separate to the Trussell Trust. So the Trussell Trust run most of the food banks in Nuneaton and Bedworth and outside the areas Coventry as well. But this was set up independently to recycle the waste surplus food from Ocado and it had operated for the last 4 years. And for various reasons, this hot potato was going to close if we didn't step in. And we were using some of the produce for our luncheon clubs to serve older people. So we were approached to see if we would take on the project, which we've done since April. So I just wanted to tell you a little bit about what we've done with Edible Links to try and improve the lives of, we've renamed the food bank to become Edible Links. I wanted to tell you a little bit about what we've done with that facility to be able to improve the lives of the people in Nuneaton and Bedworth. So Ocado are very willing to invest more money into this project to be able to enable it to get bigger and better. They see that it really reaches outcomes in terms of turning people's lives around. So to that end, they have gifted or donated 2 refrigerated vans, which we estimate to be worth probably £35,000 per year. They come with driver training, they come with insurance, they come with full maintenance contract. So on top of that, they give us food. The depot there was collecting once a week. It's now collecting 5 times a week, which is enabling us across the area to serve 840 affordable meals to people. And over the last 4 months, that's meant that there's a lot more community groups benefiting from this service, and we've made sure that a lot more of those are in Nuneaton and Bedworth and not North Warwickshire, as was the case, because our remit is around Nuneaton and Bedworth. So there's now 35 groups in Nuneaton and Bedworth that are benefiting from the service. And that can be anything from a dementia cafe who gets their tea, coffee, biscuits, sugar, and enables them then to pay the rent, up to local schools who are able to run a breakfast club for the children because they've got their cereals and they've got their bread and everything else. And that's growing, and it's growing month on month, year on year. Through the summer holidays, when the food banks were running out of food, we were supplying them with food. But how do we link this back to health? Well, in terms of health, we're looking at the stress that food-related poverty causes people and to their well-being. So if we can address some of that, we can create some headspace for them then to move on. So that's what we're trying to do. So I don't know if anybody saw last night, but on BBC News there was a coverage of what we're doing, and that's completely come out of the blue. Very interested in what we're calling our honesty shops, where we are taking the surplus food and we're taking it into communities, and we are letting people donate for it what they can rather than going to the food banks. And we're doing that because people were telling us we don't want to go to the food banks. You know, we go to work, we can't go to the food banks. We'd actually sooner go out and shoplift than go to a food bank. And these are open to anybody and everybody, and they are making a real difference to people in terms of their connectivity with communities. So they come, they pay something, whatever it is they can afford. If they can't afford money, they can volunteer. We've picked up a lot of new volunteers, and it is turning those lives around for those volunteers from a simple piece of recycled food. They are now going on to join Weight Watchers, Weight Busters. They are now going on to, you know, improve their diets. But we're having to go much further back in terms of interventions with people. It's no longer enough to provide a cheap exercise class. You've got to go much further back, really, is the message that I'm trying to bring to the table tonight. We've taken a big step backwards, I think, in terms of health inequalities in the last couple of years. I'd like to come with better news, but we're making things better, but I think that gap is certainly not shortening. And Edible Links at the moment is funded by Warwickshire Local Welfare Scheme until the end of March. It also has some money from the Borough to pay for fuel for the vans. And I think that's to a limit of about £3,000 a year. So that at the minute that's how it's funded. We have an application in the big lottery, and we should know by the end of this month if that's been successful. But otherwise, our job will be to close that facility down, which would be an absolute shame because Ocado just, can't stop giving. Really, we've increased the amount of food that's coming out of Ocado and distributed across communities by 101%, and we have been able to increase the volume of food going into different community groups and start up more community groups. It enables more community resilience to be built. I think that's it.
Okay, thanks, Sonia. I know it's always a massive worry about funding, but clearly you can show you positive outcomes, and that should help with your funding providers. Hopefully, like National Lottery, it's always a lottery where you can get some money after one.
I think the beauty of this is that we have a sustainability plan over 3 years for it. We've taken it over with the idea that this could be either a community interest company, or it can just remain under our wing as a project. But it could have, it's got a sustainable outcome. If we look at the fair share model across the country, where people pay membership for it, that's what we would be aiming to do. And if we can do that, that would then long-term support the Healthy Living Network and all of the Healthy Living Network activities as well as all the other community groups. That's a longer-term plan.
Okay, just before I bring other members in, I'm sure they're going to have questions or comments to make. I've got a couple of questions. One, we've just gone through that period of the long school holidays, and you've already spoken about, the provision of breakfast stuff at schools. What happens in those 6 weeks of the holidays? Those kids that have been able to be fed at school at an important time of the day, what happens for them 6 weeks? Have you managed to...
Well, for the children who are on free school meals, there are vouchers from Warwickshire Local Welfare Scheme that they can access. Our anecdotal evidence is that there's not a very high take-up of that. Last year, I think it was terrible, but I don't know what the outcomes are this year. They haven't done their number crunching yet. But families either don't know about it or just don't access those vouchers. The provision tends to be very ad hoc, and it's literally what the schools, what the community can and will provide. We see an increase during the summer across all of our provision in terms of families accessing it, whereas we might see a lot of older people at the rest of the year, but we see a lot of families accessing through the summer holidays. My understanding is that the sugar tax is going to be, the longer term plan is the sugar tax will be used to support schemes through summer holidays. Whether that transpires or not, I don't know, but I think that's the plan.
Okay, I'm interested to know, because I've been into Bedworth Baptist Church there, they run a food bank service there, but I think that's through the Trussell Trust.
Yeah.
And there seems to be a couple of providers of those types of service, for want of a better word. So how does your work with your own people with Edible Links, how does that fit in and not duplicate the work that the other food banks are doing?
I think the food banks are very much around crisis support. It is when people turn up, and we don't want to be about crisis. We want to be about prevention. The Healthy Living Network is and has always been about prevention where we can. So what we're trying to say is, if we can prevent somebody needing a food voucher, that would be great. If we can give people a pathway from a food voucher to actually beginning to support themselves and having choice. Because I think one thing about food banks and food packages is that they are very prescribed, there's no choice, people don't stand on their own, they just get what they're given. my vision is that that will be people beginning to stand on their own 2 feet, making their own choices. And I think there are various ways of doing that. The honesty shops at the minute is only one way. I'm looking at lots of other different ways if we get this big lottery funding that can fundamentally change people's lives and could be a real asset for both this borough, the next borough, and rugby. We're looking at rugby as well. So it would be North Warwickshire that we're trying to concentrate, because that's where the areas of disadvantage and deprivation are. But the majority of it being Nuneaton and Bedworth, because this is where the disadvantage is.
Okay, thank you. Anybody else? Councillor Margaret.
Thank you, Chair. First of all, could I think everybody on the committee hopefully will agree that we note thanks for your work and the team around you and the work they're doing, because it's really very important. I've just come from a meeting looking at housing issues, but one of the things that really shocked me was an issue around universal credit and the impact of universal credit on people's ability to afford to pay their rent and sustain tenancies. But we're also talking about impacts on health and well-being. I just wondered what sense you have, because we were talking about crisis support, what sense you have of universal credit changes within this borough may impact on people's health and well-being, and whether your work is something that can maybe help us overcome that, and also what other challenges we might face with universal credit and what we can do about it, if anything.
I think the universal credit we've not felt that real impact yet. It's coming, we know it's coming. We're working very closely with North Warwickshire and their systems. I know that this council is adopting the systems of North Warwickshire to be able to try and capture lots of information and ensure people have the right level of support when they need a food voucher. But we're also looking at the other mechanisms around the prevention agenda, and yes, I do believe we can help. We are, as I said, going back to people talking to us about needing headspace to be able to even think. You know, they can't plan to pay their rent when they can't put food on the table. If they've got children, what their immediate priority is being able to feed the children. So everything else will go. You know, so if we can feed the children, then we can get them out of rent arrears. We've done an exercise in North Warwickshire during the summer holidays where we've picked 10 families in rent arrears, and we have bargained with them, if you like is the best word, that if we provide them with food, and we actually went in the van and delivered the food to the houses, so it was as if they'd got an Ocado delivery. It was a real luxury to have this food. And we're talking quality food here. This is Waitrose, this is, you know, really good food. They paid off their rent arrears, because these were families that typically through the summer holidays fell into rent arrears year on year. And we've been able to show that by doing that, we've stopped the rent arrears, or we've stopped rent arrears getting any bigger than they were. So yes, in terms of that. And the feedback from the families is just fabulous, because they start to then engage with services. And sometimes it's the engagement with these services that is missing.
Mrs. Walker.
Yeah, yes, thanks, Chair. Really interested in the work that you're doing. From my perspective, how would the community groups access the funding, and what's the vehicle for? Do they have to bid for? You said that the community groups can access this service.
It's absolutely free. They just contact us, we give them an application form.
So in terms of the breakfast clubs then,
yeah,
that you set up in schools, how would they know that offering was there?
Okay, so through the exam period, you know, there's evidence to say that you feed a child before an exam, that will improve. We mailed out through public health to every single school in Warwickshire. We had no responses. So we did another mail out through another source, and we had 6 responses. We offered to deliver as many free cereals as the school could take, delivered to their door. We had 6 responses. Nicholas Chamberlain, let me get this right. Nicholas Chamberlain was one. Rugby School was another. I want to say St Mary's, but it wasn't. St Mary's. A rugby school was another, and the other 4 were in the south of the county. I was absolutely evil that I had to take that van to the south of the county and deliver cereals rather than in the borough. So I didn't do the mail out again when it came to going back to school last week. I used Facebook, and I put a mail out on Facebook, and I've had, I think, 20 schools, and the majority are Nuneaton and Bedworth, and they're all coming to collect their cereals. So I'm really pleased with that. So, you know, there's different ways, and if something doesn't work, you stop doing it and you try something else. Facebook's an evil tool, but it gets you to where you need to be.
And just one more, with experience I know that it's really good to deliver food and products, ingredients to families, but one of the issues that I've been involved with previously is the cooking skills of the families, and it's a generational issue that you've got generations, not through any fault of their own, but have never been taught how to cook. So, you know, you can deliver a bag of ingredients. Is any work being done on, you know, cooking skills?
That previously to be involved in this is what we were doing, and we still are doing that. But we were finding that we couldn't engage people in that because their mental health was so poor. They would come maybe to week 1 and then they would drop out. They wouldn't come back. And when we're following up and saying, "Why aren't you coming?" they're saying, "Well, so and so's happened. I've got to go and pay the rent. I've got to do this. I can't come to a cooking class because they're absolutely in turmoil and crisis." So this is why I'm saying we're having now to go further back to make interventions. So we are still doing the cooking. If I give you an example of one of the ones that we are doing, 4-week cookery course that includes free food at each of the sessions that they can take home with them, but also then, you know, what to do if you've got a family of 4. This is what you will get from the food bank. So this is what you can make with what you get from the food bank. But when people are absolutely in crisis, they don't want cooking lessons. We've got to get them out of that crisis and into a better place mentally before we can start working with them. And really that was my message to you today. You know, things are worse probably than they were. But we're doing more about it. And we're not here asking for money.
Unlike me.
Yeah, unlike chair.
Is that it? Okay, thank you. Councillor Elliott.
Thank you. I saw the honesty shop at the community day that the council put on at Barpool, and it was really impressive. And then I saw you on the news last night, and that was just so heartwarming, because talking to the person running the honesty shop that day, she said they really wanted to set up at Stockingford Community Centre that needed volunteers. And is that a difficulty getting, you said about you couldn't get the cereals into schools, it's just having people available to do it, and that's difficult, isn't it? That could fall apart, I guess, at any point.
Yeah, I mean, at the moment, because of the success we've had over the last few weeks, and the publicity we've had, we're absolutely overrun with volunteers. So we have enough volunteers, and part of that has been about service users wanting to then volunteer, which is great, because you've got a pathway. You can see, you can document how people have changed and are changing because they're staying with you. At North Warwickshire, where we run the depot and the unit, where we need really physical, strong volunteers, yeah, we're really short, because in North Warwickshire, unemployment isn't an issue. Virtually everybody there is in employment, unless they're on ESA and can't work.
Okay, thank you.
So sorry,
Sorry,
a run on from that. You are reliant on volunteers. So even if you get the funding, you still need the volunteers in place.
Yeah.
So you kind of really need more funding for staff.
Our business model, if you like, our business plan is that there are paid staff within that to support the volunteers. and allow for a turnover of volunteers, because there will be a turnover of volunteers. That's ideally what we want. Ocado have said they will favour an application to their organisation for a job from anybody who has volunteered with us, so strong are the links. So, you know, where they see a CV that says they have volunteered with us through any of our programmes, they will score higher in terms of their employment chances.
And the last thing, I thought it was Ocado and another supermarket, Lidl or Aldi.
We get a small amount of fresh
That was
delivery on a Thursday afternoon of fresh fruit and vegetables, where they do their testing up at the Aldi depot, and then all of their testing is wasted. It's what they call their purge, and they waste it, so they waste it to us, so it's weighed and wasted. Locally, we work with Sainsbury's and Tesco's in Croft Road, so we're collecting food from everywhere, and volunteers do that for us. Yeah, so we always need volunteers to help with that, but at the minute we're at capacity in terms of how many staff we've got to support the volunteers.
Well, that's really interesting about the possibility of employment. Because
And we're trying to say to people in Nuneaton and Bedworth, if they want to come and volunteer, we can pay all of their expenses to come. So we can pay for their train and their travel to come over to Atherstone, to the unit, and then they've got a CV to work up.
Thank you, Chair. I suppose I better declare it. I work for the court service, and when you mentioned rent arrears, I was interested in that. So, when you talk about people with rent arrears, do you either yourselves or through signposting others to other services go on about budgeting? Because in my experience with people in those circumstances, and I'm quite happy for you to take customers away from me if that happens, that a large part of it is about budgeting, either because there's now this assumption of responsibility that it doesn't get paid direct to the council, you should take the benefits yourself and then budget.
Yeah.
It doesn't always work for everyone, granted, but it's trying to force a lifestyle change.
Yes.
But budgeting for everyday items like food and clothing, etc., that can be a big problem for some people. Do you do signposting or work yourselves with that?
The referral forms into the food bank ensure that they have to sign up to get a referral to CAB or, you know, wherever it is in North Warwickshire. So that's the operating model in North Warwickshire. In terms of the Honesty Shop, yes, we signpost to local CAB, or, you know, even if they want some simple help, we can do some very simple help ourselves, but we try and refer and network on. In our application to the big lottery, we've put in quite a large chunk to buy in that advice service. So recognising that we're not the experts in that, but to be able to buy in that from a local provider, and then we'll be going to a local provider and saying we want to buy that in. So whether that's CAB or whether that's somebody else. But that will be our service level agreement with another organisation about what we want specifically to support those clients.
I really hope that comes off, because it's a big help to people in those circumstances, Chair.
Okay. Councillor Watkins.
So I'm just coming off what Chris was just saying there. So what sort of advice do you give them about the help that the council give? Because we've got officers that will help them through any problems that they're getting. And
so we work with the housing team here and support. So working with Jane Beards. Yeah. So we're linked in. So we work quite closely together. I mean, one of the beauties of the things that come from Ocado is it's not just food. So it can be things like if you've got a domestic violence case and somebody needs setting up in a home very quickly, we can provide towels, bedding, kitchen equipment, those kind of things. So working with officers, we've been able to identify better homes for those kind of things.
Yeah.
So it's really by working together, Chris, that we're able to do that.
Explaining how they can get on the housing list, blah blah. and also giving them advice on Carver, what different crisis loans and that are available through that, I take it,
Yeah.
and stuff like that.
We're not the experts by any
No.
means, but all we can do is be a conduit onto other organisations, because you know there are lots of support organisations within Nuneaton and Bedworth, and we don't want to stand on anybody's toes.
No.
I did have some quite negative feedback after the
The other thing I
news story last night.
was going to ask really was, do you do any work around the sheltered housing complexes that we've got? I'm not saying that you've got to be Meals for Wheels or anything, or reinvent the wheel, but for once I was seeing somebody go around the ones in my ward trying to sell fish. I was going knocking on doors.
Yeah.
Checked it out, took a photo of his number plate. It wasn't selling fish at all. So he was seen. But, you know, to have somebody going along that could be trusted going around our sheltered housing complexes, I'm not saying that they're poor in any way, I'm just saying that what work, if any, have you got planned?
We do that. We run 4 luncheon clubs across the borough, and we have a leaflet called the People's Pantry that says on it that we will do home deliveries of food. We've tried to link up with Age UK. Age UK have a programme called Care Pathways, and there's the Connect Well service as well that's run by Carver. And for the last 2 years we have been trying to get referrals for older people who are at home alone, who need a hot meal. Now it's either that the older person is too proud to ask for help, or those services are saying that there is nobody there that wants it. Now, I cannot believe that. I cannot believe that there are older people at home that don't want the services. We've mailed out to all of the shelter schemes all of this information. We've gone through sheltered housing, through the officers and through the wardens individually. I think 18 months ago, probably 2 years, we had one lady on one complex that we were going into a meal and providing meals to, because she didn't have anything in her kitchen. There was no cooker, there was nothing in there, and we were taking a daily meal into her. But then she just didn't want it anymore. And it, you know, there's only so far you can go. You can't force yourself on people. But we do rely on other agencies referring into us. And as good as we are at referring out, and I like to think that we track how we refer out to people, other people don't seem to be very good at referring into us.
Well, personally, if you can drop me some posters, and then I'll make sure that will be the shelter houses in my complex, and also in some notice boards that we've got, so I can personally do that. Well,
I know they've gone into the schemes, because I've checked that they're in there. So where we've sent them to the wardens have put them in, and they've talked to the residents about it. But I think there's that barrier that once they're in a sheltered scheme, they very much feel that that's their domain. If we were to take a meal into the sheltered scheme and they could come into their community room and have it, I'm sure they would love it. I'm sure they'd all come.
And really, it should naturally fit in to what these people were talking about as well. If you're doing care at home, you know, perhaps they're the people to link in with as well, because, you know, we're talking about support.
We link with adult social care, with the community matrons. We went and told them, we did talks to them, you know, and we still didn't get any referrals.
Right, okay then. I've got to say, it's an absolutely fascinating subject that you've spoken to us about, and I think, well, certainly for me, there was other things that I've learned from that as well. Particularly, I really like this thing where you can signpost people to other things. I'm glad you're doing that, because a lot of people maybe just think food bank or medical Linton, but once you get that link as well, people ask you something, because very often somebody in need won't go to the CAB or something, but they might go to the food bank or that type of service and then get that signposted. That's good. Right. If I'm sure the everybody here will be happy to go along with Councillor Margaret's suggestion. I was going to suggest it anyway. Just to congratulate you on the work that you're doing, and please, we'll note that as well, but please take that back to your staff and just as importantly, all your volunteers.
Thank you very much, Councillor.
Thanks, Sonia. Okay, all done? Thanks for your time, Sonia.
I'll leave some reports with Shirley, if anybody wants just an update on what we're doing over at Edible Links. And if anybody ever wants to go over to the depot and have a look and have a pack of biscuits, you're very welcome to. They always have more than enough biscuits.
Whereabouts are you?
It's Atherstone.
Yeah.
I'll send you the address.
Have you got a website then?
Doing much more on Facebook these days. The dreaded Facebook. But we do have a website. Yes, we do have a website. I'll send the link to Shirley as well. It's becoming evident that the boroughs are working much more closely together. Warwickshire and Nuneaton and Bedworth.
That's good. Thanks, Sonia.
Thank you. Good night, everybody.
Thank you.
Right, I'm just conscious of the time and we've still got quite a bit on the agenda, so I'm going to try and move things along. You've got, bearing in mind what was said to us earlier as well by, what was it, Denise? Yeah, Denise. You've got a bit of a report on, well not a bit of one on autism.
Yeah. Yeah. I tried to keep it to half an hour, so try not to go over that.
5 minutes.
Just whilst waiting for that to load up, just remind everybody that we're being filmed tonight, so I wouldn't like you to reveal any personal information either about yourself or a family member, or even somebody you work with or anything like that, because people do kind of get moments of, oh, that's just like such and such. So what I normally find quite useful is to come up with a imaginary person which I'd like you to help me with. So male or female, or it may be somebody who doesn't define themselves as either. Okay, female, and let's have a name for the female. Yep. Can somebody come up with a name for this person? Thank you. So if we ever want to refer to anybody, we're going to use Anne as the example. Okay, so you have been sent a presentation, so just to get started, you've got little whiteboards in front of you. If you just take the time, you have 2 minutes to write down everything you know about autism. 2 minutes, off we go. If you know nothing, do feel free to speak to the person next to you. Get you started, and if you've looked at the presentation, of course, your board will be full. So, Shirley, am I pressing the button? It's just these two. Okay. And that goes forward. Look at the sound work. Okay, there's some things on the screen to prompt you if you need to prompt. Okay, that's 2 minutes up. So there were 3 reasons that I wanted to do this tonight. The first is that during a previous health OSP, I think we had a doctor from Cairns here who was using the term ASD, and it turned out that quite a lot of the panel members didn't know what ASD meant, yet alone what autism actually consisted of. And I know some of the panel members have changed since then, especially this evening. And then if you read a definition of autism, they're often not very useful at all. So that was the first reason. So just to start off with, I'm going to ask each of you to pick out just one word from your boards that you're going to share in turn. I'm just going to take those. I'm not going to give any feedback or enter into any discussion at this point. It will help me know which slides that I can just gloss over and which ones need to spend more time on. So I'm just going to go around the room and one word, please. Bill?
Noise.
Noise, thank you. Chris?
Spectrum.
Thank you. Chris?
Not.
Sorry?
Not.
Not?
Yeah.
Spell N-O-T?
Yeah.
Okay, thank you. Don't know what that means.
Well, explain.
Tracy?
Interaction.
Lovely, thanks. Sam?
Disorder.
Intelligence.
Like that, thanks.
Emotional.
Thank you. Richard?
I'd had interaction, but I'll go with anger.
Anger. Thank you.
Syndrome.
Syndrome. Okay, thank you very much. So if I'm going to just read out the definition from this book, which is an amazing book. It's called Neurotribes, The Legacy of Autism by Steve Silberman, which won Samuel Johnson Prize for Non-Fiction in 2015. This is the Bible of understanding what autism really is. I'm going to read a little paragraph on the back. What is autism? A devastating developmental condition, lifelong disability, or a naturally occurring form of cognitive difference akin to genius. In truth, it is all of these things and more. And the future of our society depends on our understanding it. So one of the things, I heard Sonia use the word, things are a bit of a mess out there. And certainly with the autism services at the moment, and what Denise was speaking about, it does appear to be a bit of a mess. There's a lot of disservice done. The definitions just do not do justice to the wealth of talent and the beautiful minds out there and the things that people with autism, diagnosed or otherwise, can offer and contribute to society, and if they are given the opportunity. And the services, especially when they're very little, makes all the difference. The second reason for doing the presentation is you have a handout in your packs with the title, The Coventry Grid Summary, and these all on your tables. Coventry Grid is something devised a few years ago, 2010, by Country and Warwickshire Partnership Trust, which compares and contrasts two different conditions, autism and attachment disorder. What Country and Warwickshire Partnership Trust have become aware of is that there are similarities between attachment disorder presentations and autism, and they feel that they have diagnosed some people who are now growing up with autism when really they had attachment disorder. If they'd had with the definition on here, the definition of attachment disorder is unusual early experiences of neglect, abuse, abrupt separation from caregivers between 6 months and 3 years of age, frequent change or excessive number of caregivers, or lack of caregiver responsiveness to the child, resulting in a lack of basic trust. And they found that they had diagnosed some young people who had been subject to neglect, abuse, or separation from their caregiver at a young age. They've been put out into foster care or adopted, orphans in Romanian nurseries, displaying symptoms and behaviours that mirrored autism. And they diagnosed those with autism, then found as they got older and they weren't responding to the treatments, and they were behaving slightly differently, that perhaps they'd misdiagnosed them, given them that label that didn't fit their condition. But now the reverse seems to be happening, and many of you will be aware of this square peg group that go along to that Denise came from. There isn't a single parent in that group whose child is trying to go through the autism diagnosis, who hasn't been told your child has attachment problems. So can you imagine how hurtful that is as a parent, and giving the best care you can to your child, doing all you can to look after them, to be told that their difficulties are due to attachment disorder? It's heartbreaking, and that is what's happening. There also seems to be some kind of merging of attachment disorder and attachment problems. And we've heard that spoken about quite a lot in this OSP. We talk about the first 100 days being so important for attachment. And I get that it is. But just wanted to put it out there. The Country Grid, by the way, is 15 pages long. This is just a very short summary of it. It's on the internet, it's publicly available. It is a useful document, but do feel that it is being overused. First of all, we start off with severe autism, or low functioning as it's called, and just to have an overview of that. Just maybe non-verbal. The child appears locked in, can go into adulthood without appropriate services. Will often coincide with a learning disability. The child gets easily overwhelmed and can have aggressive behaviour, which was mentioned, I think, by Richard. A lot of wandering off. Repetitive behaviours such as rocking back and forth. Another book here called Fall Down 7 Times, Get Up 8. This is a sequel to a book called The Reason I Jump, which was written by a severely autistic young Japanese boy who's been given some way of communicating, and a little bit similar to Professor Stephen Hawking, some sort of alphabet grid. And he's able to show that even the severe type of autism through childhood can mask really high intelligence. And through the years, these children with really severe autism that they thought that they were just completely locked in, had no intelligence whatsoever, have grown up to be geniuses, fantastic scientists, amazing with computers. So there's a lot of research going on, a lot being understood about autism, but even as a child, where the autism appears to be severe, that can change with the right nurturing, which doesn't have to come at a high price. not moving, Shirley. There we go, sorry, it was me. But this form of autism, because it is severe, is much more likely to receive a diagnosis. At the moment, there's some debate over whether it's actually useful to diagnose somebody with what's called high-functioning autism, which we will cover a little bit more as we go through. Other common signs that might indicate autism, not necessarily, you might recognise in people, especially children, chewed sleeves, chewed clothing, unusual clothing, shorts in winter, coats in summer. One of the things that is common, particularly in children, is that with their shirts they'll always do up the top button, whether they're wearing a tie or not. They've got a coat, it's zipped right up to the top, because that's what zips are for. Buttons are there to be done up. Panic attacks and overreactions may fall down with a slight scrape of their knee, and they catastrophise. Can't say that word. It's the end of the world to them, and the panic from little things can seem really out of proportion. Meltdowns, which are like tantrums that toddlers display normally, but in a 7, 8, 9-year-old, and they last for hours and hours and hours and hours. The difference between a tantrum and a meltdown is that with a tantrum, if a child's in the supermarket, they want some sweets, they have a tantrum, give them the sweets, the tantrum stops. With a meltdown, it might start that they wanted those sweets in the supermarket, believe it or not. Give them the sweets and they no longer want them, and that meltdown just continues. There is no real way of stopping it, and that can be as a result of anything. Sensory processing disorder, which we will look at later, is a big predictor of these meltdowns. Loss of speech. The child can speak beautifully in the home, in the school place, is completely non-verbal. Avoidance of eye contact isn't always a sign. It is fairly common. Prefers own company. Stimming can be verbal or physical tics. Sometimes seems like Tourette's, where maybe one word. One child had the word banana that was just repeated constantly when that child was stressed for no reason. Banana, 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 banana. That's a child in mainstream school, high functioning autism. Limited foods is a massive one. There we go. Stereotype, which normally gets written down during the initial 2 minutes. Big Bang Theory, Rain Man. This is a stereotype of the extreme male brain form of autism that most people think of. The socially awkward boy, obsessed with trains, a whiz at maths and science, doesn't make eye contact, no empathy, doesn't have feelings or emotions, recognise it in others, can be tactless, make inappropriate comments, and it goes on and on and on about topics of interest to them. That's the stereotype, the form of autism that we all know. The debate that we're having at the moment, is it even necessary to diagnose Asperger's? In fact, Asperger's has been taken out of the diagnostic manual. It's no longer given as a diagnosis, which is quite upsetting to the whole community out there with Asperger's, because they identify as having Asperger's. They're now just diagnosed with autism, which comes with its own stigma. There's a quote there, I think that's from this book, Neurotribes, that half of the employees at Silicon Valley would be diagnosed with Asperger's if they had allowed themselves to be tested, which they refuse to do because of the stigma that comes along with it. at the moment, but it would be wonderful if we could change that. And they're the lucky ones that are able to get jobs, hold down jobs. And in actual fact, only 16% of people with autism are employed full time. And there is a lot of difficulty with holding down employment or even getting through the interview stage in the first place without any support or understanding of their own condition. They're just unable to get through that interview. One of the biggest difficulties with people with autism is communicating with other people. So sat in front of a panel of 3 people looking at you and asking you difficult questions, they just can't get the answers out and aren't getting through that interview stage, even though they have the skills, the amazing skills, and the ability to concentrate and get that job done. So, is there a need to diagnose, provide some help? Jury is out on that. I'm rushing through this a little bit. And then there's the problem of masking. I say problem. As children mature, they realise that going into a supermarket and having a fall-down, meltdown over not being able to have that Mars bar is frowned upon by society. So they learn to mask the difficulties, they want to fit in, they want to be accepted by their peers, and every child wants to be seen as normal. So they hide the condition. Girls tend to do this from a much younger age, but boys certainly do it as well. It takes a lot of energy. It's exhausting. Preschool children have not learnt to mask, so their symptoms are much more challenging. And witnessed a child having what looked like an autistic meltdown in a shopping centre a couple of days ago, and it was loud, and that's really, really difficult for the parents to cope with that. It's hard for people shopping in the vicinity, but really difficult for the parents who are trying to manage without having any support at the moment.
Excuse me, Chair, I have a meeting.
Okay, got a little exercise for you now. I want you to think about something that makes you feel really uncomfortable, or a fear that you've got. There's a spider there, because that's quite a common one, being supposed to be somebody trapped in a lift. Whatever it is that makes you feel scared, can you come up with a suggestion, Tracy, for people that aren't scared of spiders or claustrophobic? Something that might make people feel uncomfortable or sort of really scared. Heights is another one.
Lays with the spiders, to be honest.
Okay, so nice picture. Chris, can you help us out with something that...
Doing long speeches. Doing long speeches.
Public speaking, yeah. Okay, so think of something that makes you feel scared.
Crowds, but I don't get many up the city now,
Okay.
Crowds.
With people with autism, it's social anxiety. Makes them feel as uncomfortable as you do if you're scared of spiders and you're sitting there with a tarantula right there, or a snake around your neck, or you're balancing on a high wire and you have to get through your whole day like that. You're a child in school sitting there at your desk with 5 spiders on your desk running around, and nobody else is afraid of them, just you. You have to pretend you're not afraid of them, you have to just carry on, You have to listen to what the teacher's saying, you have to do your work, you get on, and you're coping with that the whole day, you're masking, you're hiding that fear, and that it causes a lot of stress and anxiety. Okay, right. The sensory processing disorder that Denise mentioned seems to be coming out of the woodwork as a standalone condition. It overlaps with autism. If people get sensory processing disorder diagnosis, it isn't recognised. So I'm a bit confused as to why that is being, parents are being told, go and get a sensory processing disorder diagnosis for £425 or whatever it is, because then it's not understood, nobody really knows what it is. People know what autism is and they overlap. They say you can have sensory processing disorder and not be autistic, but most autistics, the majority have sensory processing disorder. And if you look at the definition of sensory processing disorder, it's almost exactly the same as autism. So a little bit confused about that, but what that is a hypersensitivity of all of your senses. Noise was mentioned. Noises, really, really loud. Small noises that nobody else notices, like a clock ticking, can feel like a drum banging to that child with autism. The picture there, some logs. I heard Anne describing lying in bed at night with a duvet on top of her as feeling like having wood on top of you. It's uncomfortable. Labels and seams in socks and clothes can be really, really as uncomfortable as wearing clothes made out of bark. And that's what these people are dealing with all day, every day. One of the common signs of autism in children in severe autism is that they strip off. And when the children get home, they're down to no clothes whatsoever. That's one of the kind of classic signs frowned upon by society. So it's hearing, sight, all of your senses be hypersensitive. And this next, that hasn't worked either. This next clip demonstrates this really well. Might need the lights turned off. Sam, if you could. And lights, please, again, Sam. Let's say information video called Too Much Information, which is what your autistic person is dealing with every single moment of every day, which is quite challenging. So, a person with autism has a strong desire to be able to feel in control and to be able to predict situations. That's why they really do need routine, predictability, and the ability to have some time in quiet, without flickering lights, on their own, during every day, every single day, just to prevent that sort of overload and meltdown occurring. So, okay, show of hands, has autism increased over the last 5 years, 10 years?
Autism or diagnosis of autism?
Okay, so what do you think, Richard? It's just the diagnosis?
Just the diagnosis?
No, not the prevalence, no. Is that what you think?
Possibly. In honesty, I don't know, but I would have thought it's more recognised than it used to be, for sure.
Okay, definitely is more recognised. So does anybody think that the prevalence of autism has increased? You do? Okay, Chris? Not sure.
I'd probably go along with the diagnosis of it.
Diagnosis,
Yeah.
rather than the prevalence, which is absolutely correct. But also, autism is classed as a neurological condition and environmental. What does environmental mean? Speaking to somebody recently, and she said that, oh, that's things like lead, isn't it? It's vaccinations. But no, it isn't. It's just the conditions of the environment that you're in. That's a schoolroom that some of you may recognise. Tracy may not recognise, because schools don't look like that anymore. They did when I was younger. You sat at your own desk, working largely on your own. Classrooms now are noisy, chaotic places. It's all about teamwork. Some classrooms are as loud as school canteens. So the overload and the chaos for the child is greater today. Apart from that, used to start school later. I think it's just come in now that these 30 hours of free childcare for 3-year-olds. 30 hours a week for a 3-year-old who has autism is massive. They're not ready to be out of the family home. Now, I'm not going to say anything on mums going back to work, whether that's a good thing or not. That's not something I want to get into. But it's certainly taking young children who aren't able to mask, they aren't able to manage their conditions, and putting them into a classroom or a nursery for 30 hours or more a week, but they're not able to cope with that. In some countries where they say they don't have autism, they're not starting school until they're 6, where they've learnt to manage their reactions to things. Libraries. The library in Tile Hill in Coventry runs a silent hour for autistic children. When I was a child, libraries were silent places. They're just not now anymore. The last time I was in Nuneaton Library, I actually heard the staff in there telling the children to be louder, like they were at a pantomime. they were having story time and the children were having to respond, and they were shouting at the top of their voices. So the person with autism that used to get along very well in the library, spent hours and hours in the library, doesn't even have that respite anymore. And of course, research on the internet. If your child is coming home from school and hitting you and biting and melting down and stripping off and not sleeping through the night, you can go and do your research on the internet. What is wrong with my child? And so it's parents being informed and then going out and seeking that help and support. There's so much information there on the internet. The world now is much more chaotic altogether. It's not just schools. There are way more cars on the road, and life is just run at a more chaotic pace than it ever used to be. Noises out there. Supermarkets also run this quiet hour at 9 o'clock once a month for families with autism to go shopping. Whereas years ago, you used to go and do your get your meat from the butchers, pop next door, get your groceries from the greengrocers. The quiet hour introduced at Asda, it says it's an hour without electronic distractions such as escalators, music, display TVs, the public address system. You never used to have all of that. So the child walking through the supermarket with a parent was quite relaxed and calm because it wasn't all this sensory information overloading them. The massive crowds in the supermarket just wasn't the same sort of experience going to your local small store. You knew everybody. More environmental things. In the past, you could be quirky and unusual and just be called eccentric. They seem to have lost that definition now. You don't hear people being called eccentric. They are diagnosed and classified. You don't have religious orders to such an extent where the person that craved quiet and order could just go and become a nun or a monk and live out their life. Maybe not the life that everybody would want, but there were more options to be eccentric or have some differences. Apparently there's no autism in the Amish community. I don't think I've said that right. How do you say it? Amish. A lot of people say that's evidence that vaccines cause autism because they don't tend to get vaccinated. Autism has remained constant over 1,000 years. It first actually started to be recognised during the Victorian time when schooling became compulsory. It just wasn't known about outside of the home before then. Children, they used to be diagnosed with childhood schizophrenia and were locked up in institutions with some quite horrific results. But the Amish community is quiet. They don't have the bombardment of the senses that causes the overload. Nice, orderly, old-fashioned. So the autism wouldn't even be noticed. Autism in girls. Some of the research shows that boys are 15 times more likely to be diagnosed than girls. In actual fact, Asperger, who first came up with the term autism, said that it's a condition that only boys get, girls don't have it. They've now decided, and Asperger also renounced his initial findings, that girls are just as likely to have autism as boys, and also lots of boys have autism in the same way as girls do. They're not the stereotypical male form of autism that stereotype showed earlier. Girls are much more likely to mask because socialisation is more important to girls. It's more important through the way that they're brought up to have friends, to be friendly, to be accepted. It doesn't worry a lot of boys so much. They'll just do what makes them happy. But many boys do try and fit in and mask their symptoms as well. And girls, much more likely, be interested to have a bit of an obsession or fascination with things like TOWIE, the only way is Essex, than trains or computers. So, in fact, the diagnostic tools that they use to diagnose autism work with the male, it's called the extreme male brain. They work with that pattern. So even if they manage to get referred for a diagnosis, girls and the boys who present in the same way as girls, the non-stereotypical, are much less likely to get that diagnosis. They have the same difficulties. This book that I bought tonight called Odd Girl Out by Laura James, and she's recently done the rounds on TV and shows, the news and so on. She's a 43-year-old, very successful journalist who got diagnosed, got diagnosed at the age of 47 with autism. She'd been in psychiatric hospitals a few times, having had massive breakdowns, postnatal depression that hospitalised her, and it all turned out to have been non-diagnosed autism, and she's carried on being as successful as ever she was, but now she understands herself and accepts herself. I think it's in a later slide that it shows that suicidal ideation, wanting to kill yourself, is something like up to 95% higher in non-diagnosed people of both sexes with autism. So diagnosis is really important. The masking that this earlier slide showed, exhausting, utterly exhausting, which is what makes it difficult to stay in school the whole week. Lots of autistic children end up being homeschooled. It's difficult to stay in employment. Leads to mental breakdowns, depression, and a massive one is anorexia. A lot of teenage girls who find themselves in a unit being treated for anorexia, actually that's when they get discovered to have had autism. The anorexia is their way of coping with it. Gender dysphoria is another way that the autism diagnosis comes about. Gender dysphoria, I'll have a slide coming up next on that. That's an area where there's lots and lots of current research. Alcoholism in later life, not necessarily because they're non-diagnosed autistic, but that's another area that research is happening. Gambling, ways of trying to cope with not fitting in and finding life so difficult, and even turn into drugs, possible masking of the autism. So the diagnosis and the support may be a little bit expensive, but saving money in the long run massively. So just some references down there for an organisation called Girl with Curly Hair, and this book, Laura James' Odd Girl Out, tells you an awful lot about the lack of diagnosis and recognition of autism in girls. Gender dysphoria is where girls with the traditional stereotypical type autism who aren't interested in the normal things like fashion, hairstyle, and don't feel that they fit in with their peers, and they sometimes interpret that as being born in the wrong body. They should have been a boy. During their teenage years, and they want to have a sex change and seek that out. Doesn't mean that every girl that thinks they're a boy is autistic, but there's a lot of correlation just coming to light at the moment. And likewise, boys who feel that they're more sensitive than their peers, they don't enjoy rough sports, they don't want to be in the football team, they don't like going out socialising, drinking. They'll sometimes interpret that as they were born in the wrong body. And what further exacerbates this is the Education Policy Institute last year said that almost a quarter of the children referred for specialist mental health services have got turned away. So I've already touched on the number of people under the radar who are trying to get on with their lives with non-diagnosed autism. And even with children, even though it was rising because there were more diagnoses happening, that seems to be reversing now. It's harder and harder to get a diagnosis, and always has been that children presenting with anything other than classic autism are much more likely to be diagnosed with anxiety, depression, dyspraxia, dyslexia, PDA, that's being disobedient, a new condition that's coming out, attachment disorders up there, poor parenting, that's probably the biggest one, poor socialisation, or just plain naughty, needs a good smack. Completely missing the fact that it's autism causing the problems. Why is it not being diagnosed? One of the reasons is just the cutbacks in the services. Also the EHCP, which is the Educational Health and Care Plan, which a child with an autism diagnosis gets, is a legally binding document, binding on the local authority and local health services. It's expensive, or it can be expensive. So there isn't the money out there to give the diagnosis, so if they can get away without giving that diagnosis, why wouldn't they? Apart from that, we heard tonight about some of the lack of positions being filled. On the National Autistic Society website, there's advice for going to your doctors to get referred for an autism diagnosis. And you have to take a definition of autism with you to your doctors, who will not know about it. Most people just think autism, don't really know what that is. You're looking at me in the eyes, you can't have autism, you must be depressed. I have these antidepressive tablets, off you go. Massive on eye contact, which, yes, people with autism struggle to make eye contact. Boys particularly will avoid looking at you because it's so uncomfortable, because you look like a great big horrible spider to that person. Why would they want to look at you? But they do, because they know that it's expected. So therefore, if a child does have a diagnosis, and this is something else that you do hear quite a lot, I'm sure it's not limited to just education, that they've bought that diagnosis. Anybody can get a diagnosis if they pay enough for it, or, you know, give me that child for a week and I'll cure him, I'll teach him how to behave. If that child does have a diagnosis, it's highly unlikely to have been given lightly. I'm going to flip through these slides. this is quite a good illustration of why even minor changes can be so devastating to somebody with autism due to this need for security, sameness. A child going into a classroom and being made to sit in a different seat to the one that they normally sit in, to them that's like waking up from an accident to find that you've had your legs amputated and just to be told, okay, you haven't got any legs now, just get on with it, your life's going to be different, but off you go, get on with it. You don't get time to process that because everybody else just deals with it. But for the child with autism, sometimes the adult with autism, a tiny little change, somebody cancelling a dinner date on you, somebody arriving for that dinner date 10 minutes early, feels as drastic to that person as waking up having lost your legs. But society expects you to just deal with it. It's only a minor change. Why are you making such a fuss about it? Don't be silly. But that's what it feels like, tiny little changes. So 85% of autistic children leave school at the end of the day utterly overwhelmed by sensory issues. They've been holding it in all day long. They get home and they are physically unable to do anything else for the rest of the night. They can't possibly think about doing the homework. Why, if you've spent all day with spiders on your desk, would you want to go home to your bedroom and get the spiders out again? You avoid them. You get home and completely melt down. So sometime during the school day for that child to be alone, unobserved, without people around them, without noise, lights. One of the big myths about autism is that there is a lack of empathy. They've now decided that in fact people with autism have enhanced empathy. They are far more empathic than the average person. So if you're feeling sad, the autistic person doesn't just know you're feeling sad, they feel sad themselves. So that's another way that emotions can be really overwhelming. So they just can't cope with so many emotions and so many things going on. So they kind of, it's the masking, they appear to be detached. It's just because it's so overwhelming. And something that I actually heard in here is that children copy their parents' behaviour. Well, they're taught to display those autistic symptoms because their parents are so anxious. It's been really difficult as a parent not to be anxious if your child is displaying all of those behaviours, is melting down at the slightest thing. You could be the most calm, laid-back parent ever. You will soon be turned into a bit of an anxious wreck, trust me. So every day that an autistic person goes without diagnosis, they have no self-awareness. I was reading something just this morning, a person that was just diagnosed, and she used the term, I thought I was a crap person. I was unable to cope with anything. Everything overwhelmed me. I was just a rubbish person. This is actually a typing error. It's supposed to say sparrows and penguins. That's an analogy where a penguin is brought up by sparrows. Penguins are quite often people's favourite bird or animals. Penguins are really quite endearing and loved by a lot of people, adults and children alike. If a penguin is brought up amongst sparrows, can't fly, has a silly walk, it's going to feel completely inadequate. So when it's released into the penguin community, it suddenly accepts it itself and realises that it's worthwhile and does actually deserve to be loved. Neurodiversity is the latest civil rights movement. So no more pathologising, acceptance and celebration instead. These are some nice books. All cats have Asperger's syndrome. Oversensitive hearing, scampering at the first sight of being stroked, and very particular eating habits. But we accept cats and we love cats for who they are. All dogs have ADHD.
Are we nearly there,
All
Trish?
birds
I'm
have
not
anxiety.
trying-
We're
Trish,
very, very nearly there.
Because otherwise we're going to be...
So, yeah, last couple of slides. Some of the reasons to celebrate autism. One of the things about autistic people is that they're very rule orientated. They love rules, and that can be perceived as quite pedantic. If we reframe it as conscientious, reliable, honest, there's actually pages and pages of reasons to celebrate autism, and I've narrowed them down to just 2 pages. A propensity for intense research, obsession, which is how inventions happen and things get done. They're not likely to idle away their days talking about the football on the telly last night. They'll concentrate and get on with the job in hand, and if they're able to even get through the interview and get the job in the first place. So, last slide, Bill. Awareness is good, acceptance is better, and celebration is best. Neurodiversity is just one strand of diversity, like gender, race, ethnicity, sexual orientation, etc. So we need to move away from wanting to cure, normalise, and just to accept somebody for the things that they can offer and bring to society. So no time for any questions or feedback. So if there's anything that you would like to know, if you write it on that whiteboard, I will collect them all in and just email any suggestions or answers. Thank you.
Okay,
Sorry, it was
thanks,
long.
no, thanks for that, Tricia. We can certainly raise my awareness of it. Can I just say, in normal circumstances, I'd move an extension of standing orders to complete the business, but I actually think we've got that much business left. What? Well, I'm going by what I've got on there, there's 4 items.
Yeah, but it's with those 2 things. That's just a brief information. The only thing is the health performance, of which there isn't any. I just have what the sentence is to say.
Right, sorry?
It's a work programme.
Yeah. Just
I'm being advised we won't be that long then, so can I move an extension of standing orders to enable us to finish the business that we've got?
Indeed.
Okay, thank you. Okay, we've had the presentation from Trish. It's kind of, you know, we are meant to be a scrutiny panel, so it's kind of what do you want us to do with that really? I think my thinking on it is we can forward comments to the cabinet member, which would be Councillor Longdon, I would think.
If I can just explain why it was tonight. I think at the next OSP we've got CAMS coming in to talk about autism services. So it was just to kind of explain everything before they come in and say that there's a rise in attachment disorder. that sort of thing. So they're I think they're down for the next OSP. Is that right, Shirley?
To be honest, without my...
That's my understanding
but
of what it was tonight.
it is due.
So it's just an awareness raising.
Yeah, no, that's fine, but I would rather us at least point out to the portfolio holder the responsibility for health about the awareness side of it and how we as an authority can do anything to help. I don't know what we can do. It may be that things have to be passed on to the county. I can think of lots of things which I don't really want to go into tonight. You know, housing, recognising some of the things and how we accommodate families with people that's got autism, etc. But also we want to be sure that the county education people are receiving the proper training to be able to do that recognition. I mean, if I give an example, this is the type of thing where dyslexia wasn't it's kind of more understood now and recognised, and it's largely about awareness. Okay, so we're happy to sort of make those comments to Councillor Longdon. Right, let's try and move on a bit then. We've got the health performance report, page 51.
Just to say, Chair, that the Chair, Councillor Shepherd, asked for, or she would like the other OSPs, to have a performance report come to this meeting. She's had some meetings with the report writer, Steve Gore, about what we could bring and what would be suitable. And him, her and Rachel Jackson and Kevin Hollis have come up with a few indicators. They are not in this report tonight because we've only just started to monitor them in order to put them in. The idea is that we'll receive them half yearly because the nature of the indicators won't allow us to see any trends over a very short period of time. So the report has come tonight, but it is just the risk register and the strategic report, performance report that normally goes to Cabinet. So if anybody's got any questions in relation to either the risk register or that report, I'm happy to take those questions and get answers for members.
Anything at this point? Because it can go to Cabinet anyway, that's another opportunity for members to do that. So
that is as much as I would like to say on that report, Chair.
Okay, and it's still to be developed anyway,
yes.
So I think I don't really like using the word no, but we recognise the report that's been given.
I was going to say, if anybody has anything specific that they think we ought to start to monitor or look at in particular, just let me know and we'll see if we can sort something out to include in the later reports. Okay.
Item 12.
Item 12.
Was the Chair's update on the...
Oh, sorry, we're on 11. Have we got to 11?
No, 11 was... Oh, sorry. Yeah, I've jumped one. Health store funding.
Everybody should have the update that's been provided by Public Health. I don't think it actually says anything more than they said last time they were here at the last meeting, but I think that's because we've had this meeting a little bit before the meeting where they're going to discuss it. So, but they've given us what they can, and we will come back to you with any further update on that. Hopefully the body referred to in there will come up with a solution as to how we're going to fund that service going forward.
Yeah, I mean that's really important that does come to us, that we're able to look at that, because it was in serious danger of being lost altogether. So we've got to keep a close eye on that. Okay, so that will remain as an item. Right, so that takes us on to item 12, Chair's update on the STP.
There was nothing, sorry.
No. Well, I'm going to say, I'm only standing here for the Chair, I've not been briefed on anything, so there's nothing there. And similarly, with the social care and health, is that from the county? Yeah, it's from the county, isn't it?
Yes.
The chair attends that meeting, so would normally update.
Yeah, so clearly there's no verbal update or anything, but if you talk to the Chair and see if she's got anything to say, you can always pass that on. Now then, item 14, the work programme, the new items, are they ones that have been suggested to add to the
Yes.
programme that we've already got? 'Cause it seems quite lengthy, is it?
We've received 2 requests, both from Councillor Margrave. One is in relation to breastfeeding and being a breastfeeding friendly town. I made some inquiries with regard to this just because I thought the panel might need to know, and that was that this is dealt with by our environmental health team. It isn't a very large area of their work, but they do have some input to it. And so Diane Coopey, who's the responsible officer here, gave me some information from a Mary MacDonald with South Warwickshire Health Visiting Service, and it seems that they are doing some work in this area. So if I can just provide you with a little bit of information. She says, South Warwickshire Health Visiting Service is working with the local environmental health across the county to develop Warwickshire Welcomes Breastfeeding Directory. By clearly signposting that directory in local establishments, women will feel empowered and welcome to feed their babies in public. Breastfeeding welcome signs will inform mothers that they are welcome to feed on their premises and would then be given to mothers at antenatal and so on. At the start of this year, powerful new evidence funded by the Gates Foundation, published in the Lancet, delivered a resounding verdict that breastfeeding saves lives and improves health in every country in the world. It helps reduce obesity, cancer, diabetes and leads to higher IQ. But the Lancet report has also found that women are constantly failed by society in which they live, because without supportive environment around you, breastfeeding can become almost impossible. Now I understand that Diane is wanting or has started to try and do something in the town with local businesses. Now, whether you want her to do a report on this, to bring to this panel, or whether you want to look at it as a panel yourselves, I'm open to your suggestions.
Thank you, Chair. The reason I raised the issue, really, 2 main reasons, was first of all, just to think how we as a local authority are using our corporate existence, power, etc., to promote breastfeeding, because we know it has health benefits. So whether that's internally in the building, having posters or safe spaces, but also how we're working with businesses in the community across our borough to make sure that we are a friendly town. But I think really what I was asking for was that maybe a future report that could contain something about this could explore that issue. I don't think we need to have a task and finish group or anything incredibly complicated. It just needs to be really knowing that we're doing something and that it has positive health outcomes.
I am aware that Diane has tried to do some work with comms, and I'm not sure, but there may be something in touch this time on this subject. So, but we're trying to do something.
Yeah, hopefully, but it's actually a good point. We could possibly be, and I don't know, it's for others to the decision makers, so to speak. I mean, I don't know what policies we've got, if any, in regards to our own buildings, this town hall, area offices, community centres. You know, we should be setting an example of being able to promote such a stuff. So I think, if anything, that's the type of, sorry, maybe I'm jumping the gun because you need to agree or not agree. Maybe that's the type of comment that we need to ask the Cabinet, you know, because we don't make decisions, they do.
I agree with that, Chair.
I was going to say the same sort of thing really, is I think we ought to see what our own stock has got, as in like the town hall, the civic hall, community centres, if we've got if we've got areas or anything. Perhaps have a report on that first, if we're going to lead on it.
And the other item, Chair, was
Adult Neuro Development Services.
yeah. Again, this was Councillor Margrave. In his request, he said, can we have a presentation on the Adult Neuro Development Service? I believe it's important we know about this new service diagnosing adults with ADHD, ASD, etc., which I think sort of ties in with what we've heard tonight. I'd also like some stats on the number of people in the borough with autism or suspected, as well as services we have. So maybe, I don't know, Sam, maybe it would be an idea for me to ask CAMS to add that information into their report when they bring that.
That's absolutely fine. It might also be useful if we could potentially have a presentation from the new team. I know that the CCG have only recently set up this new team, and they are now operating in Nuneaton. My concern at the time was, my understanding was they were not operating in Nuneaton, they were operating in Rugby and Coventry and Stratford, and I felt that local people were potentially missing out, but I understand they are operating here now. So I mean, they could just send information to members if that's more appropriate, but I know that we were talking around the issue and it was already on our agenda, and I just wanted it to sort of slip in there so that we didn't miss out on adults as well.
See why not, but at the end of the day the chair will have to manage it. Okay, you there with that?
And we had that last item.
Yeah, and we did have one, any other item which I took, which was Councillor Longden, wasn't it? So, Councillor Longden's Health and Wellbeing Board report on safeguarding children.
Which I'll give you a copy of. So that's
Okay, so unless anyone's got anything.
Thank you, Chair.
Can I thank you very much for your attendance. Declare the meeting closed.
No?